Hello, good morning. Nitekare from Tama in Complex Goroka. I am Nalisa Neuendorf. I am a research fellow and social science lead here at the PNGIMR. We are coming to you once more again this year from Eastern Highlands Province for the Virtual Symposium 2023. Save Tambuim Sik, Improving Health Through Research. Our teams in Port Moresby, Madang, Kokopo, Alatown Maprik, welcome. And of course, our amazing IT support team. I'm going to say thank you in advance because I know how important they are to helping us run this program smoothly today. So teams in Sydney, here in Goroka and in Madang. I identify as technologically advanced. Let's correct that. Technologically disadvantaged. So having the support is invaluable for something like this today. So we at the IMR approach this day with an equal amount of stress, anxiety, and excitement. The excitement certainly outweighs the stress and anxiety at some point. So check in with us later on today and see how that's going. Having said all of that, we have another really exciting program and a chock-a-block schedule of sessions and presentations today. Given the theme of the symposium this year, Save Tambuim Sik, Improving Health Through Research, the presentations today will remind us why we do what we do and to what end. The bigger picture, which is always to contribute to improving the health of our people through the work of research. On both a personal and professional note, from me, it is such a pleasure to see the work of the dynamic, innovative, and hardworking early career researchers, my own cohort, that are taking on the challenge of leading research in all of their various fields of expertise. It is exciting for me to experience with you all the path we are forging together. So at this point, I'd like to say thank you to the Buttressing Coalition and the executive management of the PNGIMR for the continued support of this really important symposium. And as we kick off today's proceedings, I want you all to sit back, relax, and comment, if you want to, of course. The chat lines will be open, so please introduce yourselves and let us know where you're joining us from today. Feel free to ask questions, make comments, and give general feedback. Representatives of our amazing team will be online to field any of your really, really hard questions only. I'm kidding. Any questions that you have will be recorded or responded to as our team can attend to them. In all seriousness, though, it's a really, really great day that's planned for us. Please also drop onto our socials or onto your socials, let your friends and family and the world know that you are joining us today. So without too much further ado, I would like to introduce this first session, which involves the Director of the PNGIMR, Professor William Pomat. We also are very privileged and honoured to have Sir Isi Kevau join us this morning, who's the Chair of our PNGIMR Council. We also have Professor Leanne Robinson, who will be joining us, who is an executive member of the Buttressing Coalition. I'm really honoured as well today to mention that we have a keynote address from Lady Roslyn Morauta. So that's coming up in this first little session today. So thank you, Prof Pomat. I'll throw over to you.
I'll sit down. Thank you, Nalisa. And thank you everybody online who's watching. Join us, come with us on this journey that we're having today to show you the research activities that we're conducting. And I'd like to initially welcome all of you who are online, my staff who are behind me to make sure that this works. Very grateful to Anne and webcast team for making sure that the IT continues to work, as well as the people on the ground here that have made sure that PNG Power has its own mind, and so hopefully that doesn't happen today. But I would like to thank Nalisa for introducing us. This is our third annual virtual symposium with a theme that's on my back, Save Tambuim Sik, Improving Health Through research. And in this session, you will hear about our scientists present some of the innovative work that they'll be presenting. We are also very, very privileged to have on Lady Roslyn Morauta with us. She's the chair of the board of Global Fund, and we're very privileged to have her with us this morning to also present to us some of her thoughts about research leading to health, improving health. And we're also very grateful as well to CA Isi Kevau, our chairman of our council, as well as a prominent Papua New Guinean, well-known doctor. And he will be also telling us something about his own experience as a physician, as well as looking at some of the research we're doing, as well as the transition that we are going through at the moment between infectious disease and non-communicable disease. So we'll hear some of that today. And as you journey with us through this morning and into this afternoon, you will come across a lot of the research that we're doing, and hopefully you gain something from it. And if you feel like you need to come and join us, please do. When we have jobs available, we'll get you to join us or join us through collaboration. And a lot of this is through partnership. So I want to welcome all of you, and let this journey begin. Thank you.
So as I mentioned earlier, Sir Isi Kevau, sorry, my apologies, Prof, will be presenting now. Thank you.
Thank you very much, and good morning to you all. In my capacity as the chairman of the PNGIMR Council, I welcome each and every one of you participating in this very important occasion, the scientific meeting. And I also express my very special welcome to Lady Roslyn Morauta for her role in the symposium, and my congratulations to her in her capacity as the chair of the Global Fund. We both met just outside, and we began to reminisce about our old days in the 60s, when you guys were still up in heaven and looking down, but not sure whether you should come down. So it was very good to, and we also talked about her husband and I playing rugby against one another at one stage, but now we are good friends. And to Dr. N. Larson, I thank you for inviting me to be part of this and asking me to make some introductory remarks. Thank you. And Professor Willie Pomat and the team, you've done very well, and my message is that you just keep going. And in all of these talks, I can never forget to that young man called Professor Michael Alpers. I hope he's on the mat as we speak, and if he's there, hi Michael Oinamo, and also to the lady that has always been looking after here, Professor Deborah Laman. And I'm sure there are others as well, and so I'm very happy that I'm part of this. I remember going as far back as 1999, I think, when Professor Alpers introduced this idea of buttressing. And I remember when I heard about it, I thought about my father. I thought that this word buttress was a carpenter's language, and my father being a carpenter. And some of you who live in Port Moresby will remember that in November, December, January, we have a big storm called Guba. And when Guba arrives at villages like Pari and Hanwabada and all the motor villages, we were all taken by that. And my father used to make sure that there was a buttress to make sure that the house doesn't fall. So it was just a coincidence that when the word buttress came up, I thought about my father's carpentry language. My observation over the years of PNGIMR goes all the way back to 1968, 1969, and that tells you how old Lady Morauta and I. My first time, I've said it before, and if some of you are in the audience and who heard me before, I apologize for repeating it, but it's very important for us to go back to history. In 1968, I was a first-year medical student camping at the Papua Medical College, the beginning of the university. And there was a big meeting held at the Papua Medical College, and it was called Kuru in Papua New Guinea and Scrapie in sheep, wherever it was, England or somewhere. And in that process, I couldn't understand what they were talking about. And that was kind of the beginning of the research that Papua New Guinea was going to be part of in due course. Then I went up to Agorka. I was a first-year medical student in 1971, and that's where we continue to hear about those sorts of work. And a name that came up was called Behavioural. So, and that was all kind of being a part of the growing, the early life of PNGIMR. Malaria, of course, is what you are talking about. So malaria, lymphatic filariasis, and pneumonia, and all of those. And the research that has been conducted in PNGIMR has been very, very good, a very high standard, and the results that have come out are very, very impressive. I looked at your program and I said, well, there's a word called elimination. Elimination is not something that we used to think about in the 60s and the 70s. It was control. See if you can control malaria, see if you can control filariasis, see if you can control pig-bell, all of those are. And I'm happy to see that this word called elimination, I know that when I used to do multiple choice question as a young student, we had to eliminate and think critically and eliminate the ones that are not important to you. So now we are going to be eliminating malaria, and the program as we go on is like that. I am reminded of a very important paper that I read in 2004. And that 2004 paper was produced, I think, by the World Health Organization, and it was on global burden of disease. And when the global burden of disease was considered in that, of course, as we all know, you divide everything between lifestyle disease and infectious disease. And the prediction was that by 2030, which is in a few years' time, the prediction was that by 2030, infectious diseases will be going down or will completely be gone. And so I guess it fits in with that word elimination. Hopefully we'll eliminate all of those, and life will be very beautiful to live in. In the same paper, it was predicted that lifestyle disease will become highly prevalent. It will take over the whole world in relation to the difference between the two. And I then looked back and I said, hang on a minute. In 1968, when I was a young medical student, up to the time I graduated in February 1973, during that time, we used to do ward rounds, and all we saw was pneumonia, TB, leprosy, malaria, filariasis, and all of those. We had never seen a case of a stroke. We had never seen a case of acute myocardial infarct or heart attack. We had never seen a case of diabetes mellitus. We'd never seen a case of hypertension. So I kind of was challenged by that, and the prediction that infectious diseases will come down, the lifestyle disease will take over, really scared me. And I thought back that we never saw that yet. And then when I had a job in Royal Prince Arthur Hospital in Sydney in 1977, I saw my first case of somebody with a heart attack, acute myocardial infarct. And I had no idea how to diagnose it because I couldn't read ECGs in those days. And so that was the beginning of an era where this new disease is already here. And I'm in Sydney seeing that. And when I came back, still in Papua New Guinea at the early part of 70 before independence, we still hadn't seen any cases of AMI and all of those. And after independence, heart attack and stroke and diabetes have come up in a big way. Every morning in the internal medicine department meetings between 8 and 10, we look at all the admissions from the night before. And those of the PNGIMR researchers who used to go to that meeting will remember that we used to see just mainly infectious disease. But now we've got two. Sorry, can you hear me? All right. So now we've got two disease groups, TB and HIV/AIDS in Port Moresby General Hospital. That's the big group. And the second group is lifestyle disease. And in lifestyle disease, we have stroke caused by hypertension, acute myocardial infarct, heart attack, and diabetes, and all of those. So my challenge is, I just mentioned that to everybody. It's just like mentioning malaria and flu in the old days. Now I'm mentioning these, and it's something that I just mentioned, and you may just take note of that, but it's a challenge for all of us in Papua New Guinea, whether you're in the clinical arena or in the research life every day. So those are some of the thoughts that I thought that I should share with people. And one of the saddest things about these lifestyle diseases is that people at the age of 35, 40, 50 are coming down with stroke because of uncontrollable hypertension. They're coming down with a heart attack because they haven't been taking their medications and all of that. So with that, I will the meeting to the symposium to go on in a very successful way. And elimination is what it's all about. And the challenge is also, what do we do with lifestyle disease as we move on? Thank you very much for listening to me.
Thank you.
Thank you, Sir Isi. Thank you, Sir Isi Kevau, for reminding us that we need foundations, good foundations, to make sure that the work that we're doing is strong. We're going to move on to Professor Leanne Robinson at this time, who's going to talk on behalf of the Buttressing Coalition.
Thanks so much, Nalisa, and morning, Olgeta. On behalf of the PNGIMR Buttressing Coalition Executive Committee, it's my real pleasure to join Professor Pomat and Sir Isi Kevau in warmly welcoming you to the 2023 PNGIMR Virtual Symposium. I'd like to acknowledge that I'm joining you from the lands of the Wurundjeri people of the Kulin Nation and pay respect to elders past and present. I extend this respect to all Aboriginal and Torres Strait Islander people, as well as First Nations people globally, and acknowledge their ongoing connection to and care for land, sea, and community. For those who may be less familiar with the Buttressing Coalition, and I thank Sir Isi Kevau for just providing a really nice background and introduction, I just wanted to mention, that it's a broad-based group of PNGIMR friends and supporters, and it was the brainchild of Professor Alpers. It consists of individual and institutional members who all rally behind and alongside PNGIMR to provide coordinated collective support for the Institute to fulfil its mandate to conduct research that will improve health outcomes for the people of Papua New Guinea. The funding that has been able to be catalysed through the Buttressing Coalition partnership over the past 3 years has enabled IMR to invest in identified priorities across IT, buildings, human resources, and career development for IMR scientists, especially the early career researchers that Nalisa mentioned earlier. And these are critical areas that ensure PNGIMR can continue to conduct world-leading research that addresses public health priorities in PNG and generates evidence that improves health globally. And I think the Buttressing Coalition is a wonderful example of how bringing a diverse group of organisations and individuals, each with their own strengths and their own network of relationships, together behind a shared goal, can achieve sustainable and impactful outcomes. And I know that we're about to hear some really wonderful examples of research that IMR is leading in partnership with communities, local, national health authorities, and collaborating organisations that is having an impact on policy, practice, and health outcomes for Papua New Guineans. So on behalf of the Buttressing Coalition, I just want to congratulate Prof Pomat, Dr Laman, and the entire IMR team on the showcase that we're about to see, and warmest welcome to everyone joining us today. Thank you.
Thanks so much for that, Leanne. Yeah, it's really important that we're plotting this, the steps that we need to take for future improvement of research. So it's with great pleasure and honour that I am presenting the keynote speaker today. Having worked in both public and private sector in PNG since 1982, our keynote speaker, Lady Roslyn Morauta, has a breadth and depth of experience and understanding of Papua New Guinea's economy, its health challenges and its peoples. As the current chair of the board of the Global Fund to fight AIDS, TB and malaria, she brings to this position years of expertise, support, advocacy and championing of the needs and priorities of these public health infectious disease issues and programs, particularly the support of locally led research. So it would be remiss of me to not acknowledge the steadfast support that she has and continues to show for the PNGIMR and the vital medical and public health research that has and is and will surely continue to happen at the IMR around AIDS, TB and malaria research work. As I said to introduce, it is entirely my honour and such a great privilege for me this morning to welcome Lady Roslyn Morauta as the keynote speaker, whose address today is entitled Improving Health Through Locally Led Research. Thank you, Lady Ros.
Good morning, everybody, and thank you very much for those very kind words of introduction. Thanks also to Prof Pomat and Dr Laman for inviting me to give the keynote address at this very important meeting. It's wonderful to be sitting alongside my friend Prof Isi Kevau, whose role in medical services, medical training and education in PNG is unparalleled. Today, I want to stress the pivotal role of local scientific research in combating diseases like HIV, TB, and malaria. Globally, these diseases have taken millions of lives. And while global efforts matter, local research provides invaluable insights into disease patterns within unique cultural and environmental contexts. And it is through global and local collaboration that these diseases will be beaten. I'll share insights from both a global standpoint as chair of the Global Fund and a local one from my tenure as chair of the PNG CCM and my observations of the PNG IMR. Starting globally, 2 decades ago, it's not very long, 20 years ago, AIDS, TB, and malaria appeared insurmountable. However, in 2002, the world united, forming the Global Fund as a response to these pressing pandemics. Since then, the Global Fund has mobilized and invested over $55 billion, saving 50 million lives and halving the death rate from these diseases in the countries where we work. Currently, we allocate $4 billion annually towards combating these diseases and bolstering health systems in over 100 nations. Our mission is not only to address the diseases, but also the systemic injustices that perpetuate them. In collaboration with leaders, communities, and health workers, we amplify successful strategies and aim to ensure that marginalized communities have a voice and access to health. As part of this partnership approach, the Global Fund prioritizes country ownership. Countries determine their strategies against the 3 diseases and implement the programs that are funded. This ensures that the responses are tailored to each country's unique political, cultural, and epidemiological landscape. Local research is vital for several reasons. It offers solid data, allowing policies to be based on reality rather than mere speculation. It highlights new issues or provides insights guiding policymakers to effective solutions. Research evaluates the success of existing policies, indicating areas for improvement. Policies backed by strong research enhance transparency and accountability, fostering greater public trust. Local studies enable policies to address the distinct needs of individual communities, ensuring relevancy. And finally, comprehensive research identifies possible risks of policy options, paving the way for preventive measures. Research conducted by the PNGIMR exemplifies all of these attributes and has a huge impact on health programs. For over 40 years, IMR has pioneered studies that profoundly benefit PNG communities. I'm particularly interested in the IMR's work on HIV/AIDS, TB, malaria, and HPV, and I'm extremely proud of the partnership between the Global Fund and the IMR. A highlight of IMR's efforts is its comprehensive research on malaria, which includes regular malaria indicator surveys to update on the disease's status, mosquito population studies to monitor insecticide resistance, and research on the most suitable insecticide-treated bed nets for PNG, including the effectiveness of new next-generation, but more expensive, bed nets in PNG settings. Such studies offer a detailed understanding of malaria in Papua New Guinea, informing targeted interventions and also influencing prevention strategies. The IMR's research on HIV within PNG's socio-cultural landscape has revealed specific transmission patterns, guiding tailored prevention and treatment plans. A great example of this is IMR's landmark Counting Me Too survey, conducted collaboratively with the Zobi Institute, led by Associate Professor Kelly Hanku. Recognized as PNG's most extensive study, its findings are consistently relied upon. Applauded globally, Counting Me Too is the first biobehavioral survey to incorporate comprehensive point-of-care testing for HIV, viral load, TB, and STIs, forging new grounds in surveillance. It showed the country that point-of-care viral load testing was feasible and clearly influenced the Central Public Health Laboratory to take this up, even though it took 4 years to do so. Counting Me Too has become the foundational data for HIV, STIs, and TB estimations in PNG. It offered the only comprehensive data on key population HIV treatment cascades in the country and produced widely cited reports and over 10 scholarly articles enriching global research. Impressively, the lead lab scientist from the project is now at the University of Queensland, focusing on vital research that promises to influence PNG's treatment strategies for HIV. I understand that a new biobehavioral survey in Port Moresby is being planned by USAID FHI 360. I really hope that they look to PNG IMR's capacities and Counting Me Too successes. The Counting Me Too survey strength stemmed from the local leadership of IMR and pooled resources of the Global Fund, DFAT, and USAID. Collaboration, not siloed efforts, is crucial for our shared success. Local research shapes the Global Fund's contributions in PNG. As I mentioned earlier, research informs country disease plans and funding requests to the Global Fund. For the current cycle, 2021 to 2023, the Global Fund has invested up to $106 million in Papua New Guinea. These investments, rooted in PNG strategies and research, aim to combat HIV and TB and counteract the recent spike in malaria. They also help mitigate the impact of COVID-19 on these programs. An additional $77 million has been allocated for the next cycle of grants. The current HIV and TB grant, $67.5 million, is implemented through World Vision and focuses on elevating the number of individuals aware of their HIV status to 95%, boosting those on antiretroviral treatments to over 90%, and ensuring 95% of TB patients receive drug susceptibility tests and achieve an 85% treatment success rate. They're the aims of the grant and the programs. Meanwhile, a $38.6 million grant implemented through Rotarians Against Malaria backs PNG's ambitions to reduce malaria morbidity by 65%, cut mortality by 95%, and eradicate transmission in select areas by 2025. Notably, about $1.8 million US of this grant is being invested in IMR during the 2021-23 cycle. So we fund as well as use research. Over the past 2 decades, guided by local research and focused efforts, HIV mortality in PNG has dropped by over 70% since its peak in 2006. TB deaths declined from 109 per 100,000 in 2002 to 46 per 100,000 in 2019. And despite PNG's high malaria transmission, highest in the region, with the Global Fund support since 2004, we've scaled up interventions like long-lasting insecticidal nets and rapid diagnostic tests. We cannot, however, rest on these successes. Latest estimates indicate an increase in HIV transmission, especially amongst young women and girls and pregnant women, in turn affecting a higher number of babies. And all anecdotal evidence suggests a worrying increase in TB, while malaria still remains a leading cause of presentation at a health facility. There will no doubt be challenges ahead, both in the fight against HIV, AIDS, TB, and malaria globally, but also here in PNG. But I do believe AIDS, TB, and malaria can be beaten. Indeed, by working together, we're getting closer to achieving the goals the world once deemed impossible, ending HIV, TB, and malaria as public health threats. And it's pivotal work of partners like IMR that gives me hope. I commend the PNG IMR team and its technical partners, Kirby, Burnett, and others, for your deep insights that shape disease programs. Customized, culturally sensitive health interventions and vital evidence to guide health investments in Papua New Guinea. I urge all development partners, including DFAT, USAID, FH1I360, to collaborate with and support PNG IMR. IMR role is crucial both for local health advancement and for our united global effort against these diseases. Let's champion and invest in local scientific research. Thank you.
You got a rousing round of applause here in the Goroka Library. Thank you so much, Lady Ros, for your presentation, for your address this morning. It gives a lot of us younglings a lot of enthusiasm and excitement about what we can contribute to in the years to come. So thank you very much for your time this morning. And just a little bit of housekeeping before we move on to our scientific program. If you're joining us and would like to get yourselves involved in the chat, make sure you hit that refresh button so you can get the latest chats, and then you can be, it's a little bit more interactive and live at that point. So thank you. So we're going to move on to our first session this morning. And so we're going to go on a journey through malaria control. And then we'll talk about research developments. And then Oh yes, sorry. Thank you, boss. Our malaria control funded by Global Fund. Thank you, Global Fund. So from malaria control to research developments here at the IMR, to talk about the molecular hub, really exciting triumphant partnership that our POM lab team will be talking about. And then we'll end the session with Dr Elishebah Malau, who's one of our early career researchers. The spotlight will be on her. And then after her presentation, we'll have a short break at around 11:45. So let's have a journey through malaria. Thank you. Thanks.
Greetings to you all from wherever you're joining. I am Dr. Joseph Kidathuri, a Senior Research Fellow and leading the Malcon Operational Research Team at PNGIMR. Today, we will delve into the journey of malaria control using insights from Malaria Indicator Surveys. I look forward to sharing our findings with you all. Let's get started. We will begin by setting the stage with the background of Malcon, offering a clear perspective of its origin and purpose. Progressing forward, we will highlight Malcon's significant milestones, underscoring our major achievements in the fight against malaria. A closer look at Malcon's structure and function will provide an insight into its organizational dynamics and operations. Our focus will then shift to the Malaria Indicator Survey. We will discuss its objectives, study design, data collection process, and important findings. Subsequently, we will address the real-world impact of our operational research, specifically on the PNG National Malaria Control Program. Throughout, various members of our team will present, and we will have the opportunity to see visuals from our fieldwork, providing a first-hand view of our operations on the ground. Let's proceed.
The PNG Institute of Medical Research has 15 years of experience evaluating the PNG NMCP. And this all started in 2004 when the country received its first grant from the Global Fund to fight AIDS, tuberculosis and malaria. And in 2008, the PNGIMR was contracted to perform an independent evaluation of the NMCP. And since 2009, the Institute has continued doing that under the project called Malcon. And these Malcon activities, they've been numerous. They included, for example, large-scale national malaria indicator surveys to assess intervention coverage, or health facility surveys looking at quality of care. We established sentinel surveillance sites to look at malaria trends. We also started some entomological studies that now developed into a large-scale program. We conducted therapeutic efficacy studies, drug quality studies, and some other operational research activities. Probably the largest and most important activity are the malaria indicator surveys. And so far, the PNGIMR has conducted 5 of these national surveys, and the 6th survey is currently being implemented and about to be conducted. The PNGIMR teams have covered all provinces of PNG in the context of these surveys. They've visited more than 540 villages, interviewed more than 15,000 households, and collected over 65,000 blood samples. We are very happy to support these activities as Swiss TPH, but of course there's been a number of other institutions from around the world supporting these activities. And in the coming few minutes, you will hear a lot more details about what we've been doing in the past and what the results of these activities were.
As mentioned earlier, the Malcon team conducted its first Malaria Indicator Survey in 2008 with the aim to evaluate the program activities like the distribution of bed nets and scaling up of malaria diagnosis in health facilities by improving microscopy and introducing rapid diagnostic tests. The Malcon team was successful in conducting a broad and comprehensive survey, indicative of our organizational and logistical capabilities. The 2008 Malaria Indicator Survey provides a benchmark for understanding malaria epidemiology in Papua New Guinea. The high quality and efficient work demonstrated by the Malcon team in 2008 MAS significantly influenced the Global Fund's decision to continue supporting our malaria research and control efforts in Papua New Guinea to this day. As part of the National Malaria Control Program monitoring and evaluation activities, The Malcolm project established several sentinel surveillance sites to support longitudinal monitoring of malaria morbidity trends alongside intervention coverage indicators, for example, net ownership in known populations. These sentinel sites in PNG have compensated the National Health Information System by providing trends in malaria incidence and contributing substantially to identify malaria drug resistance markers. Some of the initial sites have changed over the time, and present we have 8 sites being operated by the multiple projects within PNGIMR in collaboration with Malcolm. From the outset, the Malcolm project has spearheaded several groundbreaking initiatives focused on the growth of its team and committed to excellence. Here are some of our highlights. While the NDOH considering adopting the new malaria treatment protocol in 2009, the Malcolm project carried out a critical efficacy study evaluating the efficacy of artemether-lumefantrine as first-line treatment and dihydroartemisinin piperacin as a second-line treatment. Our team's training is global in scope. Several Malcolm members have engaged with the top institutions for further studies and training. Some of these include master's program at Swiss Tropical and Public Health Institution and the Australian National University. And also we offered an open data kit training for the Malcolm data manager at Swiss TPH and a PhD program at the University of Basel in collaboration with Swiss TPH. And we are proud to highlight that since 2008, PNGIMR stands as the sole government institution in PNG to be a Global Fund subrecipient. In the current Global Fund grant cycle, the PNGIMR has contracted to conduct 3 major activities under Malcolm project. The first one is a National Health Facility Survey, and the second one is a National Malaria Indicator Survey and entomological activities like insecticide resistance monitoring and bed net durability assessments, and then the batch testing of the bed nets that are distributed in Papua New Guinea. The first activity is the National Health Facility Survey. The main objective of the HFS is to provide updates on the availability of infrastructure, equipment and consumables, healthcare worker training, knowledge, and treatment practices to implement malaria case management at health facilities across PNG. And if you're interested, please scan the QR code available on the screen to get the latest HFS report. Before going into the details of our next activity, Malaria Indicator Survey, let's have a look at Malcolm organizational structure. This team is an integral part of Population Health and Demography Unit of PNGIMR. This unit is led by Senior Research Fellow, which has 2 parts, Project Scientific Unit and Project Management Unit. Project Scientific Unit comprises of Senior Scientific Officer, Scientific Officers, Research Assistants, and Research Nurses. When the teams travel to the field, Scientific Officers leads the team, and each team comprises of a Scientific Officer and a Research Assistant and a couple of Research Nurses. And our supporting team has Project Manager and Admin staff. And Malcolm has a dedicated Senior Data Manager who is expert in RDK. And we also have 2 more teams, Microscopy team and Entomological team. These 2 teams are under the supervision of Vector-Borne Disease Control Unit in Medang. Now we will look at Malaria Indicator Survey. So the main objective of Malaria Indicator Survey is to measure malaria prevalence and malaria control intervention coverage at population level and track progress in these indicators over the time and inform the policymakers accordingly the evidence needed to guide national malaria control program. Malaria Indicator Survey is a household-based cross-sectional survey that we conduct in all 22 provinces of PNG. The sampling procedure remained consistent across all 6 malaria indicator surveys. Using a 2-stage cluster sampling method, villages for the survey were selected from the 2011 National Census databases of villages. A random sample of 5 villages were selected per province. Additionally, We always had an equivalent number of backup villages selected, excluding those initially selected. On occasions where a village was inaccessible due to logistical or security issues, we would rely on the backup village close to the original selection. Upon our arrival in each village, the survey team leader, in collaboration with the local representatives, would establish a household census. From this, we would then randomly select up to 30 households for our survey. Here you can see the screenshot of the random number generator app that we use to randomly select 30 households from a village. We use 4 standard questionnaires to conduct Malaria Indicator Survey. And the details of these instruments you will get to know later in this presentation when our scientific officer explains the process of data collection with the visuals from the field. And before commencing of MAS, all the field investigators receive adequate training into these instruments. And in the next slide, you will see how we correspond with PHAs to conduct MAS in the provinces.
In the Malcolm project, we work closely with the provincial health authorities to conduct surveys. Before our teams go out to the provinces, we reach out to PHA officials. We give them a letter that includes results from the past MIS, an explanation of why the current survey is important, and 10 randomly selected villages for the MIS. A PHA officer or the provincial malaria supervisor then helps us identify the first 5 randomly selected villages out of the 10 villages. This way we get information about how easy it is to access these villages and if there are any security issues. At the same time, while waiting for PHA's approval, our project management unit makes a schedule of data collection for the 5 villages and works out the service budget. Our PR team rotates against malaria reviews and arranges for our team to go to the provinces. Throughout all this, we maintain regular contact with the PHA until the survey is finished. This ensures everyone stays updated and the survey process runs smoothly.
We start our fieldwork by visiting the Provincial Health Authority in our designated province. At the PHA, we meet with essential personnel like the CEO, Director of Public Health, Disease Control Officer, Malaria Supervisor, and District Health Manager. The goal of this visit is to communicate our survey plans and request the assistance of an accompanying officer for our survey period. We also visit the closest health facilities of the selected villages and occasionally ask a health worker to join us in the villages. Our work continues in the selected village where we initiate an information session with the village leaders and community members. These crucial steps aids in gaining their trust and securing permission to conduct our survey. During our operations, we compile information about households, establish a list of households, and randomly select 45 households, factoring in a 50% rejection rate. Information sheets are then handed out to these selected households, which highlight the objectives of the study and clarify that participation is voluntary and we maintain confidentiality strictly. Following the receipt of consent from household heads, we proceed to survey 30 of the 45 initial selected households. Next, we dive into the core of our project, conducting the actual survey using structured electronic questionnaires programmed into tablets using Open Data Kit. We use 4 different forms in our survey. The survey begins with the household head questionnaire. This is a structured interview conducted with the adult heads of participating households. It gathers information about household characteristics, including socioeconomic status of the household, insecticide-treated nets availability and usage, participation in malaria-related behavior change campaigns and other interventions, and personal data about each household member. Following the household head questionnaire, the team administers the treatment-seeking questionnaire. In this stage, we engage with those household members or their caregivers who reported an illness within the last 2 weeks. The interview aims to understand the signs and symptoms of the illness, their treatment-seeking behaviors, the sources of treatment, and types of drugs administered, if any. We pay special attention to febrile illnesses and strive to collect more detailed information about such episodes. The third phase involves the women's questionnaire, conducted with female household members aged between 15 and 45 years. This questionnaire aims to collect data on the birth history, which helps us to calculate child mortality estimates and the exposure to malaria intermittent preventative treatment during pregnancy. Finally, the prevalence form. Our nursing officers collect finger prick blood samples from all members of the participating households who are 6 months of age or older, present at the time of the survey, and agreed to give blood. Nurses perform rapid diagnostic tests for malaria, measures hemoglobin levels for anemia, examine children aged 2 to 9 years for splenomegaly, and provide necessary treatment or refer them to the nearest health center. Upon finishing interviews and blood sampling, we thoroughly review all forms for accuracy. Once we are done with a village summary form is filled out to record village coordinates, the total number of households in the village, the approximate population of the village, and additional comments if any. We return to the place of residence to upload data to ODK's central server, cross-check blood slides, and finalize the village summary report. This meticulous process ensures accurate and reliable data for our survey. That's a snapshot of our fieldwork process, and with each village surveyed, we take another step closer to our goal of a healthier PNG.
The project, in its almost 10 years of existence, has achieved and improved significantly, both scientifically and operationally. One significant accomplishment was the transition of data collection from paper-based to electronic data management using Open Data Kit, ODK, which is an open source software. The entire process of data management, from form design to data management, is fully controlled by the data manager at IMR in Goroka. This is the third round of MIS, where ODK is being used for data collection and management. Ever since its introduction, data processing time has substantially decreased. As the scientific officer mentioned, data is uploaded to an ODK central server from the field. This is contrary to paper-based methods, where data processing goes through multiple processes before producing a final dataset for data querying. Another significant development in this round of MIS is that the project has introduced ODK for microscopy data entry in MEDE. Microscopists are using QR codes to scan blood slide labels, and the microscopy results are directly entered into ODK and uploaded to the server by the microscopist. The project takes pride in this remarkable transition, which has significantly minimized errors and provided almost real-time updates during the survey.
I will be presenting the main results from 6 malaria indicator surveys done so far. Papua New Guinea Institute of Medical Research has conducted malaria indicator surveys in more than 500 villages and surveyed more than 14,000 households in Papua New Guinea. Except for 2019-2020 MIS, few provinces were not surveyed in other 5 MIS due to security reasons. Malaria prevalence has decreased across Papua New Guinea in both general and children under 5 populations from 2008-2009 to 2013-2014 by 9-folds. In 2016-2017, malaria prevalence increased by 7-folds in the general population and 6-folds in the children under 5 population. In the last survey, 2019-2020, the prevalence of infection with malaria parasites decreased in both populations, but were not lower than the seen record in 2013-2014 survey. On a provincial level, in the 2019-2020 MIS, malaria prevalence in the general population was less than or equal to 1.5% in 15 provinces. That is 4 provinces in the southern region, 1 province in the Emcee region, and 3 provinces in the island region. Household ownership of nets and LLINs declined in 2019-2020 compared to a steady trend during the previous 4 surveys. Similarly, the proportion of households owning 1 net per 2 people has decreased, indicating a decline in the number of nets in net-owning households. The 85% target of household ownership of at least 1 LLIN has not been reached on a national level. Overall, access and use of any net and LLINs in the general population, in children under 5, and in pregnant women declined in 2019-2020 after being largely stable between 2013-2014 to 2016-2017 surveys. On a national level, the targets of 75% LLIN access, 60% LLIN use among all age groups, 65% use in children under 5, and pregnant women were not reached.
Okay, the information collected through MIS is used in conjunction with our normal data system, which is the ENHIS. It sort of tells us, tells the program on the various strategies that we need to focus on. So when IMR gives us a completed report, then of course that is used together with the ENHIS to see if we do have any. I mean, usually it should be similar, but that sort of paves the way for us to decide on different strategies that we want to employ for the program. Well, as I said a little bit earlier, the Malaria Indicator Surveys are actually more or less evaluating the program. So it's an independent sort of survey that is taken on. We can collect the same kind of information from ENHIS, but when you look at the surveys, it is an independent survey which is done independently. So this needs to be continued, otherwise we do not focus on the direction we'd like to focus on.
To sum up, our Malcolm team has faced many challenges. We have dealt with security issues, local conflicts, and many other problems, yet we have managed to carry out our important malaria surveys across the nation repeatedly. We have done this even with some budget limitations and comparably small share of the PNG Global Fund budget. We have shown you today the background, milestones and structure of Malcon and some key points of PNG Malaria Indicator Surveys. You have seen visuals from our fieldwork and heard from our team. For all the Malcolm project reports, please visit the PNG IMR Research Publications page by scanning the QR code on the screen. Despite the obstacles, we have stayed committed to our mission. We'll keep working hard to fight malaria. We would like to thank the Global Fund, NDOH, and the National Malaria Control Program, Rotarians Against Malaria and Swiss TPH, and all other global and national partners. Thank you for joining us today.
I hope everyone enjoyed their journey through malaria control. Really appreciate the team for putting that presentation together. Next on the agenda for today is Dr. Moses Laman, who's the Deputy Director, Science and Research here at the PNGIMR. He's going to be talking a little bit about the research developments at the PNGIMR, and this will be a live presentation. So thanks, Moses.
Thank you, Nalisa. Hello, everyone. Great to see you all. At the IMR, there are a lot of research developments ongoing at the moment. Just to update everyone and our collaborators about what we are doing at the moment. There are a lot of changes. In fact, at the moment, the Institute has about 401 staff. So we are in the growing phase of the Institute. A couple of years ago, between 2011 and 2016, we were at the decline phase and the number of staff really declined. We were not able to attract international competitive research grants. And over the last 10 years, we have worked really hard to restore credibility at the IMR, and a lot of research development has been happening since then. In May this year, we had a research agenda workshop to try to brainstorm on some of those agendas that are important for the country and what we can do to improve and develop the research programs at the IMR. As you all know, at the intersection where research meets implementation, we have those many challenges still, where you could do good research, but how to implement them often take many years. And those are realities of operating in a developing country like ours. But through the partnership of the national government and the National Department of Health and provincial health authorities, we've been able to unlock some of those barriers. And the Institute is currently going through a growing phase at the moment. In fact, 60% of our budget comes from the government of Papua New Guinea, and we're really thankful to the government for supporting us through this. But research is also really growing. Out of 401 staff, 56% of all the staff are employed through research grants. Only 177 staff are employed through the government co-funding. In terms of what are priorities going forward, we all know we still have huge challenges in the health system and limited resource, and the health system aims to serve the rural population, and those are huge challenges. So those were agendas that we looked at very closely on how to improve on with regards to research agenda. The lack of data in some important aspects of health services in Papua New Guinea, as well as research agendas that we'll need to be addressing. And sometimes it's not always lack of data, but limited use of existing data and how we could utilize those or work with partners within the country as well as externally to find evidence-based, to support evidence-based decision-making in those aspects. The poor state of maternal and child health in the country is well known, and those are agendas that we really want to address in Papua New Guinea through research as well. Of course, the changing pattern of morbidity and mortality fueled by social, economic, and cultural environmental changes like climate change is an important agenda in contemporary Papua New Guinea and globally as well. And those are important agendas that we are not forgetting in terms of research agendas as we move forward. And as we heard from CA Isi Kevau, Chairman of the IMR Council, about non-communicable diseases that are affecting our country at the moment, this came up very strongly in our research agenda as well about how do we incorporate and strengthen non-communicable disease research in Papua New Guinea through the IMR research programs. And on that note, we would like to welcome collaborators or those who have expertise in non-communicable disease to come and work with us at the IMR or collaborate with us. Obviously, in research, you need strong leadership, and anyone who thinks who has an interest in this space or have the track record, we are inviting you to come and support us to build a non-communicable disease program at the Institute. With regards to how we are trying to strengthen and improve research at the IMR, there's been an organizational structure change within the IMR, where this was obvious during the COVID-19 pandemic, where we had to support the government in the national program when there were no point-of-care testing available. Labs had to be converted to COVID testing facilities for the country. And those were huge challenges that have been identified. And how do we move forward as we look at communicable disease as well as the rising burden of non-communicable diseases? How do we look at outbreaks and surveillance response as well, as highlighted during the pandemic? And so through that, we have also reestablished the outbreak and surveillance unit at the IMR and also strengthened the population health and demographic unit by strengthening it with social and behavioral research that can work across the IMR and with partners as well. And the health economics component of research, you could have a good tool that shows good safety and efficacy in the community, but what does it mean in terms of community acceptance, and the social behavioral aspects of it. So holistic research ranging from public health to social science research to medical research is an important way, and how to approach it would be really important for us. In terms of infrastructure development, we are working hard to create a conducive research environment for the Institute and for collaborators and for partners within the country. And we are thankful to the government of Papua New Guinea for the 100% funding for the Medeng Infrastructure Lab and Office Complex. This 30 million lab is on schedule to be completed next year. And we are thankful also to the Buttressing Coalition, who continues to support us through many different ways. And this virtual symposium is one way. The Buttressing Coalition is supporting us, but also through infrastructure development, and infrastructures have been supported, maintained, refurbished through the Buttressing Coalition support as well. Our relationship with government, the health department and provincial health authorities have never been better. And we are so thankful to the support of the government and our partners locally as well as internationally. In terms of research, we would not be able to achieve this without the support of our many, many international partners who continue to support us. So on that note, I would like to finish and say thank you all to our collaborators locally and internationally who continue to support us. And thank you to the more than 120 people who are online and supporting the IMR through this virtual symposium. Thank you.
Thank you so much, Dr. Laman. And just drawing on what Moses has been talking about with partnerships, before we go into the next presentation, partnerships are vital to what we do at the PNGIMR and in growing what we do. And I'm glad he gave a shout out to the social and behavioural research that happens at the IMR, because we don't have a presence on presentations this year, but it is vital also as an aspect of public health research. Also, shout out to everyone that's watching. I hear we've got viewers from the Gold Coast, from Menzies Institute, from Divine Word University. So welcome, everybody. Please keep sending in your comments and questions, and let us know where you're tuning in from today. So on that note of partnerships that Moses has just been talking about, and also Leanne and Sir Isi Kevau talked about this morning, we're going to move on to our next presentation, which is about the Molecular Hub, which is a partnership that is between the PNGIMR, UPNG, CPHL, the National Department of Health, the Burnett Institute, and other international partners. So we'll be hearing from our Port Moresby lab team to talk about the Molecular Hub.
So the UPNG-PNGIMR Partnership in Health Lab was established in 2011, and it was focused on non-communicable diseases and TB research through our Population Health and Demography Unit. So these projects then enabled the establishment of clinical diagnostic capacity here in our lab, which then enabled us to contribute to research projects that evaluated TB diagnostic tools and determination of sources of extrapulmonary TB. So these projects were made possible through collaborative research projects with the Burnett Institute, the National Department of Health, the Port Moresby General Hospital, provincial health authorities, and the Central Public Health Lab. So since 2019, through Strive PNG and the Trilateral Malaria Project, we are now focused on vector-borne diseases research projects.
Through the Trilateral Malaria Project, the IMR developed strong partnerships with in-country partners. And when we worked more closely together, we realized that we had a limited pool of technical experts, equipment, and facilities in molecular diagnostics for malaria in PNG. So in 2019, partners from the University of Papua New Guinea's School of Medicine and Health Sciences, the Central Public Health Laboratory, Burnett Institute, and PNGIMR came together to establish the PNG Molecular Hub. So we established the PNG Molecular Hub by pulling our molecular testing equipment, our personnel, and facilities in a collaborative research space. So the Molecular Hub is situated in the Medical Sciences building at the School of Medicine and Health Sciences Tarama campus. And our partnership expanded, taking a One Health approach when NACIA, the National Agricultural and Quarantine Inspection Authority, joined the hub as a partner in 2020. At the Molecular Hub, conventional PCR and genomic sequencing assays are performed at the SMHS Genetics Lab, and serological testing and real-time PCR are conducted in the PNGIMR Partnership in Health Lab. Our established molecular assays identify the pathogens causing infections, and our serology assays measure immunological response in people to tell us what they have been infected with previously.
Over the years, the Institute has supported CPHL and the provincial hospitals throughout the country with outbreaks testing for neglected tropical diseases such as dengue and chikungunya, and also we've provided support for testing for vaccine-preventable diseases like pertussis and measles. And current routine surveillance for these diseases includes case-based reporting and vaccine coverage estimates that have been obtained from hospital records and household surveys. Strengthening of routine surveillance of infectious diseases is very important for Papua New Guinea, and one strategy that can be used to strengthen and complement routine surveillance in a cost-effective approach is the use of serological surveys. Serological surveys measure the prevalence of immunological responses or antibodies and are useful for firstly assessing antibody levels and before and after the rollout of a vaccine, also for monitoring changes in disease transmission following outbreaks, and also for identifying populations that remain at risk of infection. Here at the Molecular Hub, we have successfully established 2 high-throughput multi-pathogen Luminex serological assays. And the first assay measures in one sample antibody responses to several neglected tropical diseases pathogens and to pathogens covered by the vaccine programs in the country. The second assay measures the level of exposure to SARS-CoV-2 and other respiratory pathogens among the general population using samples collected by the STRIVE PNG project. Data generated from serological surveys will strengthen decision-making for public health and social measures, and also for diagnostics, therapeutics, and vaccination.
If I had to highlight a particular success outcome from our partnerships, I would share our success in transferring the Molecular Hub PCR assays to the Central Public Health Laboratory. It was through our partnering that we were able to train and establish our malaria and arbovirus PCRs. And it is our hope that these assays will be fully integrated and eventually rolled out to CPHL's regional PCR testing sites. Samples we test in the lab are collected from 8 Sentinel sites across the country. These sites were strategically selected for biosecurity reasons, and sample collection made possible through the partnership and support of local public health authorities and health facilities. Samples are sent via courier to the hub, where we extract genetic material for molecular testing through our established PCR assays. We have established PCR assays to determine which of the 4 species of malaria is causing infection in fever cases presenting to our Sentinel site clinics. We also have PCR assays that detect dengue, Ross River virus, Bama forest virus, chikungunya, Zika, and a generic test for flaviviruses like Japanese encephalitis, Murray Valley encephalitis, and Sipic and Kunjin virus.
And seconded to Central Public Health Laboratory. So my role here is to develop malaria PCR assay, and that is to confirm malaria species and to build malaria slide bank in Central Public Health Laboratory. And the main reason to have the slide bank is to have them as reference material, to use it as external quality assurance purposes in PNG, as well as for training of malaria microscopes throughout PNG, as well as training students in malaria microscopy. During the time, I was also able to be engaged with the molecular hub, and because of the trilateral malaria project, the molecular hub came to be at present. So that sort of involves collaboration with CPHL, PNGIMR, and School of Medicine and Health Sciences. That's to have scientists within 3 organizations to sort of collaborate in developing assays or research in malaria in PNG. So what I find very useful is that to have the partnership or collaboration, and that kind of helps us to sort of leverage resources together, and the resources involve like technical expertise, equipment, and all that. So for example, some of our equipment in CPHL, we had to move it up to the molecular lab so that could be used for research purposes between all 3 of the institutions altogether. So the successes that I had achieved during my time when I was collaborating with the molecular lab is that we were able, because of us collaborating, we were able to build capacity for COVID-19 diagnostics, and that's involved the 4 regions of the country. We have the islands, Momase, New Guinea Islands, and Southern region. Secondly, one of the successes was for me to coordinate transfer of assays like dengue PCR, that includes serotypes 1 to 4 and other vector bonds as well. That's secondly. And thirdly is supervising students from the Bachelor of Medical Lab Sciences department to validate 4 different RDTs that they currently used by the National Malaria Program in the country.
I joined the PNG Molecular Hub team as part of the STRIVE PNG project, I think about 3 years ago, and I have been part of the team contributing to PFHRP to gene detection, developing the technique, the assay, and also I am involved in bringing students in and engaging them in the PNG STRIVE project. So the STRIVE project trains the students, and the students carry out the research as part of their end of year research project. I am also part of the PNG Molecular Hub team involved in genetic sequence analysis. Last year, our team has analyzed coronavirus gene sequences from infections in PNG, and we would like to expand or bring this work into malaria parasites, especially Plasmodium falciparum, histidine-rich protein 2, and also the malaria drug-resistant gene sequence analysis, since we have just recently established the assay to carry out the detection of the multi-drug resistant genes.
I'm here as Assistant Scientific Officer attached with the Division of Basic Medical Science, School of Medicine and Health Sciences. I've been involved in the supervision of students doing molecular biology project. The main task I've been supervising students doing year-long project attached with our strive in the trilateral malaria projects. And also COVID-19 diagnosis during that outbreak. The highlights, we've been training of students in advanced molecular techniques, training of our plan is to look into training students in advanced molecular technique and also training of the School of Medicinal Science staff. Okay, and one big achievement, I think, with the partnership, we actually happen to have a refurbished School of Medicine and Molecular Genetics lab.
Diseases as well as pathogens of biosecurity concern. Samples for PCR testing in the past, as well as present for samples that we don't have capacity in country yet, were always sent to the World Animal Health Organization Regional Reference Laboratory, which is CSIRO ACDP, the Australian Centre for Disease Preparedness. With the African swine fever set up in country, NACIA is able to provide critical information to the Chief Veterinary Officer to respond immediately to suspected cases, as well as facilitate important decisions in national emergency animal disease response. Two other very important transboundary diseases, foot and mouth disease, as well as lumpy skin disease, have also been set up in country for PCR. And this is important because these are diseases that would have detrimental effects on PNG if they entered our country, and at the moment it is in our neighboring country, Indonesia. The PNG Molecular Hub provided NACIA with molecular training for staff and the facilities to conduct testing in country. This was achieved through collaboration and support from the PNG Molecular Hub as well as CSIRO ACDP. Sharing their experience and skills allows NACIA to upgrade our capability as well as enables us to share these skills and experience with our own staff. NACIA supports the PNG vector surveillance by assisting with insect sample collections in locations where NACIA is established or has networks, and as well as providing an office within NACIA Port Moresby to facilitate vector surveillance. NACIA is also planning to support the PNG IMR Infection and Immunity Unit with fresh sheep blood for cultures. How do we see the PNG Molecular assisting NACIA in future? Initially, the work between NACIA and the PNG Molecular Hub was through an ACR project for the detection of flaviviruses, which was the ZAPA project. Since then, this has developed to better linkages and partnerships between human and animal health agencies, and we hope to see this collaboration and cooperation continue and strengthen, and having a more collaborative One Health approach.
When the Molecular Hub was established in October of 2019, we initially had low throughput testing capacity. It was through the Strive PNG project that we increased to high throughput capacity. This was around the time that the pandemic hit, and we were in a good place to support nationwide COVID molecular testing alongside our colleagues in PNGIMR Goroka. Our lab team at the time comprised of seven members who worked together to support more than 10,000 PCR COVID tests. At the time, we had members of our clinical staff supporting in the lab. We also supported training of CPHL staff to initially establish molecular testing for COVID in the lab. The Molecular Hub also supported confirming new COVID testing platforms for private hospitals and other labs during this time. Support for COVID testing came through many local and international partners, particularly the Australian DFAT. Post-COVID, the equipment and consumables continue to support the other work that we're currently involved in for surveillance of diseases affecting people and people and animals, and monitor factors like drug resistance. The work we do is enabled by our local and international partners who we work closely with. As we're all aware, PNG public health facilities currently don't have all of the tests required to understand what's causing people to get sick. So it's the molecular data that we generate contributes to, here at the hub, through our surveillance system, contributes to helping us understand what pathogens are circulating in PNG and what people have been exposed to. So this will hopefully guide resource planning, interventions, and programs by the National Department of Health. So we're working closely with the National Department of Health to ensure that our research is aligned to NDOH priorities and strategies, particularly in the vector-borne diseases programs. We're working on developing molecular testing frameworks and strategies for vector-borne diseases affecting Papua New Guineans. We're working with NDOH partners on developing molecular testing frameworks and strategies for vector-borne diseases. We're grateful for all our partners who support through funding or in other ways, and we look forward to working with everyone to integrate molecular surveillance and genomics into programs to support health improvement for Papua New Guinea. Thank you from the PNG Molecular Hub team.
Hi, good afternoon. Welcome to Central Public Health Laboratory and welcome to Molecular Hub program in this country. My name is Willie Brown and I am the director for the Central Public Laboratory under the National Department of Health. It has been really amazing to see the Molecular Hub expanding in the public health programs as well as the research through a strong partnership from our project partners, and it has been advancing in terms of the PCR technology. And one of the benefits that we're seeing that going to be based on the outcome is the aligning this activity to the National Health Plan 2021 to 2030, in which one of the main key result area is the targeting the health disease, especially the outbreaks and response surveillance, etc. So I really am delighted to say, thanks to all what the partners are doing at the moment, in collaborating with the implementing agencies such as PHL, PNGIMR, and University of Papua New Guinea. And we hope to see this continue so that the molecular technology in the outbreak response and surveillance strengthening will be the way forward in this country. Thank you to all.
Right. So thank you to the Port Moresby lab team and all our research partners for that presentation about the Molecular Hub. It's really, really great to see that we're having these really strong partnerships and collaborations that help us to develop our scientific skills in these areas. Scientific skills is probably not the right word to use, but very important to advance the work that we do in our labs. I want to give a shout out to everyone that's tuning in right now from different places. So we have the Burnett Institute in Melbourne. Shout out to you, Mob. To the Burnett Institute Daru team. Hello, everybody. The National Research Institute in Port Moresby. To the PNG Science Technical Council in Port Moresby as well. Solar Solutions Port Moresby, welcome. Thanks for joining us. And to DFAT officers in Canberra and Port Moresby, welcome and thank you for joining us today. So the last presentation in this session is actually a spotlight on one of our early career researchers, Dr Elishebah Malau. And her presentation is entitled When Friend Becomes Foe, Only Skin Deep. So we'll throw to her for her presentation. Thanks, Dr. Ellie.
Well done.
Oh, I forgot to say break, but I can say that after.
Hello, my name is Elishebah Malau, and I'm a postdoctoral research fellow with James Cook University and the PNG Institute of Medical Research. And today I'll be presenting about a project we are going to be doing here in the Highlands region, and it involves looking into the emergence of community-associated methicillin-resistant Staphylococcus aureus. When friend becomes foe, it's only skin deep. A very colourful topic title, but there is an element of truth to this statement. Most of us are aware of the fact that our skin is home to a collection of different microorganisms, many of which can remain relatively harmless until a trauma of sorts is experienced, or there is a change in the environment of where these microorganisms live on. And when that happens, they can become pathogenic. And our foe in this presentation today is the microorganism Staphylococcus aureus. Staphylococcus aureus is carried as commensal by approximately 30% of the global population and is predominantly found in the interior nares, which is basically inside the nasal cavity. It can also reside on other parts of the body. Staphylococcus aureus is an important pathogen in the clinical practice and can cause a range of disease presentations, many of which can be minor self-limiting infections presenting in the form of boils and sores on the skin, and this can sometimes lead to life-threatening diseases such as osteomyelitis. Staphylococcus aureus is a leading cause of skin and soft tissue infections, osteomyelitis, infective endocarditis, sepsis, and pneumonia. Staphylococcus aureus is commonly associated with antibiotic resistance in the form of methicillin-resistant Staphylococcus aureus, commonly referred to as MRSA. In the early 1990s, the emergence of community-acquired MRSA was reported, and this has become a growing problem. In PNG, MRSA strain ST93 is a particular problem. It was first reported in Australia in the early 2000s, but has since been detected in Europe, Asia, and parts of Oceania. Previous research done in PNG, based on a report from the Kundiawa Hospital, showed an increase in pediatric cases of osteomyelitis in PNG Highlands since 2010. Also, a prospective observational study of osteomyelitis cases at the Kundiawa Hospital found 2/3 of cases of acute hematogenous osteomyelitis was caused by Staphylococcus aureus, and this was found to be mainly affecting children. A recent study published by Steinig and colleagues did a full genome sequence on 77 MRSA isolates collected from pediatric osteomyelitis cases, and they observed that 82% of these pediatric osteomyelitis cases were caused by the MRSA strain ST93. Also, phylogenetic analysis, as is illustrated in the images on this slide, suggests one major introduction of MRSA ST93 into PNG from northeast Queensland happened around the year 2002, some 5 or 10 years after the ST93 clone first emerged in Australia. So why are we interested in the emergence of MRSA strains circulating in the community? Community-associated MRSA strains have no association with the MRSA strains found in the hospital setting. The ST93 strain in particular is predominantly associated with the community-associated MRSA infections, and it results in more severe disease, with patients being more likely to require greater clinical interventions, longer treatment, and poorer patient outcomes. Therefore, by improving our diagnostic capabilities to determine what strains of community-associated MRSA is responsible for acute hematogenous osteomyelitis cases in the PNG Highlands, we can treat and prescribe antibiotics accordingly to improve patient outcomes. This research project is funded by the Australian Government National Health and Medical Research Council Ideas Grant, and the main aim of this project is to determine the clinical impact of MRSA-related acute hematogenous osteomyelitis in the PNG Highlands, and to identify interventions to reduce the burden and impact of this infection. This will be achieved through following 3 main objectives. Firstly, to evaluate the feasibility of point-of-care diagnosis of MRSA, acute hematogenous osteomyelitis in the PNG Highlands. Secondly, to determine the persistence and transmission pathways of community-associated MRSA in the PNG Highlands. And thirdly, to determine the diversity and phylogenetics of MRSA strains circulating in the PNG Highlands communities and their association with acute hematogenous osteomyelitis cases. I would like to take this opportunity to acknowledge our collaborators at the Australian Institute of Tropical Health and Medicine at James Cook University, the Microbiology Diagnostic Unit at the Doherty Institute, and our collaborators also here in the Highlands at PNGIMR, the Eastern Highlands Provincial Hospital, and the Kundiawa General Hospital. And thank you all for your attention.
Thank you so much for that presentation, Dr. Elishebah Malau. It's really great to hear the work that you'll be doing here at the PNGIMR in partnership with your home institutions. So we're running a little bit ahead of schedule, but we're going to have our scheduled break after this presentation now. I just want to acknowledge the 154 viewers that have tuned in to watch the virtual symposium today. So thank you so much for joining us. Please have a break, have a little bit of a stretch, have a coffee, and then come back and join us at 12:10 for the next session, which will be on the prospects of elimination. So there'll be several presenters in that last session on elimination. Also, just before we go to our break, I want to acknowledge Telethon Kids in Western Australia for joining us, the Australian Defence Force, the Malaria Infectious Disease Unit in Brisbane. Thanks so much for joining us. FHI 360, and again, our students and colleagues and faculty down at Divine Word University. So on that note, as I said, please go have a little bit of a break. I'm going to definitely have a coffee, and then we'll come back and join you at 12:10. Thank you so much. And so welcome back after our short break. We're going to run into our afternoon session or second session on prospects for elimination. Before I hand over to our boss, the director of the PNGIMR, Professor William Pomat, I just want to give a shout out to Griffith University in the Gold Coast, to the Centre for Innovation in Infectious Diseases and Immunology Research at Deakin University. Thank you so much for joining us. For all of those of you returning, I hope you had a good break, and we'll kick off with Prof Pomat's presentation. Thank you.
Thank you, Nalisa. Thank you, everybody. Thank you to all of you online who are joining us this afternoon, and those who are prepared to also continue to join us throughout this afternoon. This session is about elimination, or previously we would have gone control, elimination, eradication, and so all of us as healthcare workers look towards elimination as something that we want to achieve to ensure that the world is healthy. But we know that is very difficult. So WHO has about 30 odd diseases on its list of disease for eradication, elimination, and control. And many of these are infectious disease or infectious pathogens, and a lot of it common in Papua New Guinea. So we know that in Papua New Guinea we have malaria, pneumonia, lymphatic filariasis, HIV, Hep B, cervical cancer, and vaccine-preventable disease that are common causes of deaths here. And with our diversity, limited healthcare access, and weak health system, elimination appears to be a very, very daunting task. But ongoing research has shown otherwise. Can I have the next slide? Diseases such as malaria, lymphatic filariasis, cervical cancer, HIV, Hep B, and vaccine-preventable disease are at the center of PNGIMR's research activities, and as well as the National Department of Health. and all our partners as well. So ongoing research, those show eradication is possible. This session will provide evidence that through sound research, partnership, and conviction from all of us that this is possible. Next slide. So what are our success from a research perspective? We know from earlier on that Joseph had presented on malaria and about the declining incidence. Yes, we are seeing a resurgence now, but there's been a general decline overall. We know, for example, that we can interrupt transmission, and transmission is the main reason why we have, once we understand it, we can eliminate disease. And we know that current research, or in presentation after this, that we will look at some of the work that we're doing on radical cure for p.vivax. Also, lymphatic filariasis is also high on the elimination targets for PNG. Managing this is important for us, and there are two strategies that are available to eliminate, to enhance elimination. One is through preventative therapy using mass drug administration, which we currently have in East New Britain, and will be continue to do that in West New Britain as well. And these are looking promising. And this MDA came from research that is conducted through the Institute that has shown that it can be done. Next slide, please. Another couple of diseases, both are viral, human papilloma virus, something that continues to be major cause of mortality for many of our women. We now have, through our research on point-of-care testing, using GeneXpert, has revolutionized diagnosis, and the Western Highlands PHA is currently rolling this out, and we'll hear more about this later on in this session. And as you can see in the newspaper from Tuesday, in Western Highlands, at least over 6,000 women have been tested for cervical cancer, and this program is going really well, and elimination is, of course, on target. And our next disease is HIV. A few years ago, we would have thought that HIV would be difficult to eliminate. But now it is possible for us to prevent mother-to-child transmission, and that is part of the WHO elimination target by 2030. Next slide. And so from this, we can see that elimination is possible if we interrupt transmission. But obviously, there are challenges for us in Papua New Guinea that we need to be looking at. The geography, all of you Papua New Guineans know about that, and those of our collaborators who've been to Papua New Guinea know about that. We have difficult terrains. Health infrastructure, that is something that we need to collectively start looking at and make sure that it's improving. Our belief systems, we all have a certain belief system that can challenge us when we look at the different diseases. COVID-19 showed us that very well. And as well as that, managing multiple vertical elimination programs. If we don't integrate them, then it becomes difficult because we don't have that many experts across all the different fields. So we need to begin to look at integration. Next slide, please. What are the opportunities for us to eliminate disease? Obviously, community engagement is a big part of this. We need to ensure that we inform community well, educate the community to ensure that they understand what disease we're looking at, what it means for their health, and what it ultimately will do for the community. How do we collect the data, and then how do we educate people to ensure that they understand, we understand the data itself, so that we provide evidence-based information to our people. We build capacity. And at the Institute, these are some of our lovely women who've obtained PhDs. We are very proud of them. But we need to build capacity across the health sector, as well as other sectors, to be able to then have the opportunity to eliminate disease. Use of technology. we're currently using Zoom for this meeting to get across multiple, to go to multiple partners. And all of you who are tuning in will know about that. So using that as a surveillance system or continuing to use it or improve on it would be important for us. Earlier on, Prof Isi Kevau and others have talked about partnership. Prof Leanne Robinson had talked about partnership. The Buttressing Coalition is part of the partnership coalition that we have to ensure that this program comes to you, but also in assisting us to ensure that a lot of the infrastructure that we have is available. So partnership for all of us is important as we build on the strengths that each of us has to ensure that we head towards elimination. And as I said earlier in the previous slide, integration of approaches. Malaria and lymphatic filariasis are both mosquito-borne disease. Can we integrate some of those approaches so that we can eliminate, or at least head towards eliminating one or both of them? Next slide, please. And that's the end of my slide. Thank you very much, everybody, for watching. Thank you for your support in ensuring this program goes live to all of you. And thank you very much also for helping to ensure that we begin to eliminate disease. And in the programs after this, in this session, we will ensure that you see the evidence that we have to convince you that we can eliminate some disease. Thank you very much.
Thank you so much for that presentation, Professor Pomat, and for illuminating us and giving us an overview, excuse me, of the successes, the challenges and opportunities for disease elimination in PNG. I want to give a shout out to everyone who's returned back to this afternoon session. There's about 120 viewers. I've had a couple of messages from our teams in Madang and in Kokopo. So I want to give a shout out to Madang team who have two partner organizations in the viewing room with them. So PNG Fire Service and Madang PHA, thank you for joining us with our Madang team. And also to the Burnett Institute and PNG-IMR teams up in Kokopo who do amazing work actually across LF, other infectious disease programs, but specifically LF and malaria. So really great to have you guys join us as well. So our next presentation this afternoon is looking actually at eliminating lymphatic filariasis. So we'll go to that presentation now. Thank you so much.
PNGIMR has significantly contributed to some of the VBDU elimination agendas of the government of Papua New Guinea. And two obvious ones that comes to mind are LF, lymphatic filariasis elimination, and p.vivax, malaria. Obviously, we still have a lot of challenges in the space of malaria because we have a lot of cases and the country is still in malaria control state. But for LF, IMR has been a leader conducting research for more than 30 years with partners, particularly in East Sepik and in Madang, and now with all this body of work extending to monitoring and evaluation of the programs that the National Department of Health and provincial health authorities are leading. IMR is still a partner conducting monitoring and evaluation of these programs of work. From my opinion, I think when you look at lymphatic filariasis compared to other vector-borne diseases, LF is it's a much more easier parasite to eliminate compared to malaria because of the for malaria it's much more efficient in terms of transmission, whereas LF is not an efficient. We don't have vectors that can efficiently transmit LF, and also because of the size of the worm, it's not easily or efficiently transmitted from vector to humans. And so when you look at it from the perspective, LF is much more easier to eliminate. But obviously the challenges with elimination programs comes down to health systems and community health and other resourcing, financial ownership of the program. So there are many challenges still in the LF space, but those are realities on the ground in a developing country setting like Papua New Guinea that we will have to work towards addressing. The priority areas that will need to be addressed by our country is in relation to recognizing and having that awareness that LF is one of those parasites that can be easily eliminated, and ownership of the program, whether it be in funding or ownership in terms of being led by the provincial health authorities that know they have LF in their provinces, and all of us in the health space in finding ways to contribute towards eliminating LF in Papua New Guinea. From an IMR perspective, some of the research that we are conducting to contribute to eliminating LF, as I mentioned earlier, has been ongoing for more than 30 years, beginning with the two drug therapies, albendazole and DEC, that led to global efforts to eliminate LF, and then more recently the IDA, ivermectin, DEC and albendazole, that has now become a global program WHO has adopted. And the original studies began in Papua New Guinea and many other countries as part of a consortium project IMR has been a part of, has also provided that evidence that IDA is a much more effective effective regimen for LF elimination. And we also, from that note, we acknowledge the National Department of Health under the leadership of Dr. Lucy John in trying to amalgamate IDA with azithromycin in all other bodies of work and programs of research activities that are now happening in other parts of the country, like West New Britain province, and the PHAs in West New Britain and in East New Britain particularly, and in East Sepik and in Madang, that the LF workers, the IMR has been leading, and in partnership with those particular PHAs. And these programs and body of work have led to a real chance and possibility of eliminating LF in Papua New Guinea.
Hi, my name is Dr. Simon Westby. I'm a research fellow for PNGIMR, and I'm here today with my colleague Joycelyn Sallow to talk about PNGIMR's current efforts towards lymphatic filariasis elimination in PNG. So, to start off with, the WHO's target for LF is to eliminate LF as a public health problem by 2030. Practically, what this means is two things. Firstly, using mass drug administration, i.e. giving entire populations medications all at one time, often for several years, to reduce the amount of LF in a population below a level where transmission can no longer be sustained. Secondly, caring for all of those with chronic manifestations of LF already, such as lymphedema and hydrocele. So today I will take you through PNGIMR's research in East New Britain, touching on the two completed MNEs and the current ongoing third MNE, and then Joycelyn will talk you through West New Britain. So, East New Britain. So here's a timeline of LF research in East New Britain. You can see in yellow, 2 MDAs have been conducted so far in 2019 and 2022. And in green on the top row, you can see that 2 MNEs have been conducted so far in 2019 and 2021. I'll talk about these first. Okay, so in 2019, the first MNE used population proportional sampling when selecting sites to sample. This essentially means villages with a higher population were more likely to be randomly selected. And they sampled 6 to 9 year olds, and then separately those equal to and above 10 years of age. In 2021, the MNE sampled those equal to and above 10 years of age and used model-based geostatistics to select sample sites. So what is model-based geostatistics? Well, for LF, what it means is taking previous LF prevalence data, as well as data about other variables or covariant layers relevant to LF prevalence, such as altitude, rainfall, proximity to water, and putting all of those into a model to produce something called an exceedance probability, which is basically a measure of how likely there is to be LF in a certain area, so you can select high likelihood areas for sampling. And on the right you can see an exceedance probability map with the darker red indicating areas more likely to have LF. In general, from an LF-M&E, you'd expect FTS, a measure of adult worm burden, to stay positive in an individual for about 5 years after the MDA, whereas MF, a measure of baby worm or microfilaria burden, you'd expect that to reduce soon after the MDA. The difference between these two M&Es was about 2 to 2.5 years, and as you can see from the first line, the overall FTS percentage went up from 5 to 8.1%, representing that the MBS site selection was more effective at finding LF cases. But as you can see from the bottom line, the MF percentage went down from 1.2 to 0.3%, representing that IDA-MDA was effective in sterilizing adult worms, even after just one round. Okay, so what lessons have we learned from the first two M&Es that can help us towards LF elimination in PNG? Firstly, we've learned that model-based geostatistics is better than population proportional sampling at incorporating the heterogeneity of LF distribution into sample site selection. Secondly, sampling adults rather than children increases your chances of picking up LF infections. And then thirdly, again, the data isn't shown here because we haven't had time during this presentation, but we also followed up all of the cases that remained positive after the first MDA. And basically what we were able to show was that the ones that remained positive did so because they never took the MDA in the first place. Okay, so we've talked about the first two M&Es, and now we're going to go on to talk about the third M&E taking place currently. Okay, so this third M&E is part of the study applied research to determine stopping decisions for mass drug treatment with ivermectin plus DEC plus albendazole for lymphatic filariasis, and IIS stands for the IDA Impact Survey, which is like a new version of the Transmission Assessment Survey. The primary objective of this research is to develop an M&E strategy that enables country programs to determine when the risk of ongoing transmission of LF has been reduced so that IDA can be stopped with little risk of resurgence of transmission. When conducting MDAs, it's difficult to know when you've conducted enough rounds of treatment. For LF, traditionally the method to assess when to stop further MDAs is called the Transmission Assessment Survey, or TAS. It was developed when LF-MDA was just 2 drugs, DEC and albendazole, a less effective combination, and so TAS is usually only conducted after 5 rounds of MDA. It's conducted on a population of children aged between 6 and 7 years old, uses systematic random sampling and a diagnostic test of FTS. The cutoff criteria is an FTS positivity of less than 2% on average across the entire province. IIS was developed after IDA-MDA was shown to be more effective than DA-MDA in sterilizing adult worms, and IIS was developed to see if you could therefore assess transmission interruption at an earlier stage, i.e. after just 2 rounds of MDA. Then the question became, as we are thinking of doing fewer rounds of MDA, how do we really make sure we sample representative sites and populations to really find LF if it's still there? As we've shown for the previous M&E results, and as is incorporated into this IIS methodology, the IIS samples adults and uses, as well as FTS, it then uses MF positivity as part of the cutoff criteria. For this particular study, we'll be using model-based geostatistics for sample site selection as well. In terms of the cutoff criteria for IIS, it allows you to make more nuanced stopping decisions than TAS did, as it doesn't only look at the average across the entire province of LF prevalence, but it also looks at the average in each sample site, reducing the risk of recrudescence. Also, after this, it allows health departments to see if there are specific pockets of LF prevalence remaining, which could be subject to a targeted MDA rather than doing an MDA for the entire province, potentially saving a lot of money in potentially expensive LF MDA programs. We are currently conducting the IDA impact survey in East New Britain. The black dots represent all the villages that we've sampled already, with the pink and blue dots representing the ones we are targeting to sample, although these are weather permitting. So I'll now hand over to Joycelyn to talk about West New Britain.
Hello, my name is Joycelyn Salo, and I work for PNGIMR as the project manager for DOLF project. And today I will talk about the current ongoing research project in West New Britain province titled Integrated Control and Elimination of Neglected Tropical Diseases in Papua New Guinea. The purpose of this study is to evaluate the first integrated MDA, which involves 4 medications, and they are ivermectin, DAC, albendazole, and azithromycin. These 4 medications will treat a range of entities including LF, scabies, yaws, soil-transmitted helminths, strongyloides, and trachoma. There are 2 primary aims for this study. Today's talk will focus on the first aim, which is to develop integrated and synergistic strategies for the monitoring and evaluating neglected tropical disease programs in Papua New Guinea. And there are numerous secondary aims for this study, and today's talk will be based on the third secondary aim, which is to develop a sustainable surveillance program for entities and increase the capacity of the health systems in PNG to provide accurate and timely data reporting. So this is a slide of the timeline showing the current ongoing research project in West New Britain province. On the left, you can see, as part of the active surveillance, the first M&E which occurred at the end of 2022. And I will talk about the methods and results of this M&E first before going on to discuss the passive surveillance skin disease training. In terms of the first M&E, model-based statistics was carried out to identify sentinel sites where 43 sites were selected. In these 43 sites, a census was done to identify households, where 20 households were randomly selected and all over the age of 1 year consented. Skin exam was carried out on yaws-like lesions, leprosy, and scabies, and fingerstick blood was done to test for LF-FTS and dry blood spot, which is yet to be analyzed. This is a map of the selected villages in West New Britain province. The colored spots showed the 43 sites sampled, and notably west of West New Britain could not be sampled due to issues of security. The results shows that LF-FTS positive was 4.25%, and FTS more than 2% positive was 26% in 11 sentinel sites. MF positive was 1.5% and 1.1% with chronic LF manifestations, and 39 out of the 3,552 participants surveyed was found with lymphedema and hydrocele. For scabies, the result was 8.5%, and scabies was detected in at least 1 individual in 36 villages surveyed, which is 83.7%. Similar prevalence in both adults and children. For yaws, the yaws-like lesion was 3.7%, where 130 people were tested with yaws, and DPP test was done on 40 participants, where 14 of them were tested positive. So now I will talk about the passive surveillance program aspect of the research project in West New Britain, notably the anti-skin disease training of trainers. The purpose of the skin disease training is to train the OICs of all health centers in West New Britain on how to recognize and collect data on skin diseases. OICs from all the healthcare centers in West New Britain will be invited to Kimbe for a skin entity training alongside the MDA training. This training has already been trialed in Vanuatu and has been adapted for PNG context. The main focus of the teaching will be how to diagnose, manage, and better report the 4 skin entities, and they are scabies, yaws, LF, and leprosy. The OSCs will be provided with a skin entity flipbook and a new skin entity outpatient tally sheets, and it will be for a duration of 6 months. And the OSC will submit skin entity outpatient tally sheet monthly to prospectively collect data of these 4 skin entities as well as other skin diseases. Later on, the OSCs will take assessments of competence and confidence to assess their teaching efficacy. And we are in the process of setting up a WhatsApp group for the OSCs to support diagnosis. To summarize, for East New Britain Province, the lessons learned regarding the first 2 MNEs was the sample site selection, the sample population, and the positive case follow-up. And the third current MNE has built on lessons learned and is an exciting opportunity to see if more accelerated program of MNE surveys can be applied to IDA MDA in PNG. For West New Britain Province, the first MNE has been successfully completed and has highlighted West New Britain as suitable for MDA. And the upcoming passive surveillance research will help to achieve study's secondary goals of developing a sustainable surveillance program for entities, as well as increasing knowledge and understanding of entities within primary health service. We're going to be investigating whether xenomonitoring could be a useful part of the LF monitoring and evaluation in the future. Thank you all for listening.
Hi, thank you for still being with us for these presentations this afternoon. It's my great pleasure to throw to our next presenter, Professor Leanne Robinson, who's one of our partners from one of our partner institutions, the Burnett Institute, and who will be giving us a global context of the work being done across research spaces to accelerate the elimination of malaria. Thank you so much, Professor Robinson.
Thanks so much, Nalisa, and I'm really delighted to join you all again and to present on, the importance really of addressing what is often the quite neglected global burden of Plasmodium vivax in order to accelerate towards malaria elimination. And so I'm going to start with the global burden. I think it's under-recognised that 40% of the world's population is at risk of p-vivax. And the map here allows you to see, the very many countries shaded in orange that have a very high burden of clinical vivax malaria, and those in red with an even higher. We're talking millions of cases a year. It is the most common cause of malaria outside of sub-Saharan Africa, shown in blue, and it's associated with severe anemia and increased mortality in young children. And it's the repeated attacks that are characteristic of vivax that mean patients really endure many weeks or months of chronic illness that contributes to anemia, weakness, cognitive impairment as this chronic illness accumulates over time. And this persistence of vivax is a major obstacle to the 2030 target of malaria elimination in our region. So why is it such a persistent problem despite the implementation of malaria control tools? Well, it's because current control tools have really been designed to address Plasmodium falciparum, the biology of which is characterised by a mosquito injecting sporozoites into the human host, and these infect, these infect liver cells where they mature into schizonts, which rupture and release merozoites into the bloodstream, causing a blood stage infection, which is often accompanied by clinical symptoms. The patient seeks treatment to resolve these symptoms, and if diagnosed and treated with effective drugs, the blood stage parasites are cleared, the patient recovers, and they no longer have parasites in any organs, tissues, or their bloodstream. However, this is not the case with Plasmodium vivax, which has a unique biology, starts off being characterised similarly by mosquito injecting sporozoites into the human host. These infect liver cells, and some of them immediately mature into schizonts, which rupture and release merozoites into the bloodstream, causing a blood stage infection. But some remain in the liver as relatively dormant stages called hypnozoites. And when this blood stage infection is cleared by routine blood stage treatment only, these hypnozoites in the liver remain. They are undetectable by currently available diagnostics, and some weeks or months afterwards, they reactivate to cause another blood stage infection. And then once that is cleared, they strike again and again and again, depending on the extent of the hypnozoite reservoir in the patient's liver. And in this way, the hypnozoite reservoir causes this chronic relapsing malaria that not only contributes to chronic poor health, it also sustains transmission of vivax, with the sexual stages that are produced during each blood stage infection able to be passed on to the mosquito and subsequently infect another person. In order to effectively treat these hypnozoites in the liver, patients need to receive a specific anti-hypnozoite drug treatment in addition to their regular blood stage treatment. And this combined treatment is called radical cure. The only available anti-hypnozoite treatments are primaquine and tafenoquine, both of which cause severe hemolysis in glucose-6-phosphate dehydrogenase deficient individuals. This is an enzymatic deficiency, and it's really this issue here that has actually kind of stalled progress against achieving effective treatment of vivax malaria globally. Due to a lack of routine G6PD testing in most malaria endemic countries, a low total dose of primaquine is prescribed over quite a long treatment period of 14 days. And this 3.5 milligram per kilogram total dose is not an optimal total dose to maximise efficacy and ensure clearance of these hypnozoites. Moreover, poor adherence to such a prolonged treatment course, particularly when most symptoms have resolved after the blood stage treatment has been finished, means that the effectiveness of low-dose primaquine is reduced to more than 12% in some studies that have been done by colleagues in Indonesia. So as a result, in many settings, including PNG, neighbouring Indonesia, other countries in the region, there's a high burden of vivax malaria. And we know from studies that the IMR has led in PNG that these hypnozoite-derived relapses are responsible for 80% of vivax infections in PNG children. We know health workers throughout PNG and similar countries have low confidence to prescribe primaquine without G6PD testing, and that patients find it difficult to adhere to the 14-day regime. We also know currently available RDTs have poor sensitivity to actually detect blood stage vivax, and the work that Maria led during her PhD really showed quite clearly that intensified vector control and routine case management that's been implemented in PNG over the last decade had much less of an impact on p.vivax than p-falciparum due to that previously acquired reservoir of hypnozoites continuously reactivating. But thankfully, there are an increasing number of new case management approaches that can start to help address these issues. There are new generation RDTs that are being developed with improved sensitivity and specificity for vivax. There's novel biomarkers of infection. For example, work that was done in PNG by Stefan Karl and the IMR team showed that hemozoin is a really useful biomarker for vivax, and this has potential for an improved vivax diagnostic tool. There's new point-of-care G6PD diagnostic tools that allow a quantitative readout of somebody's G6PD activity, and this will allow more safe administration of primaquine and tafenoquine. And that's something that Mary's going to talk to you about after me, about a study she's leading around G6PD point of care testing and higher dose primaquine regimes. Because as mentioned, there's also accumulating evidence that we really need a total dose of 7 mg per kg. This has much higher efficacy than a total dose of 3.5 milligrams per kilogram. And there's also now evidence from trials that this higher dose can be safely prescribed to people without G6PD deficiency over a shorter duration of either 7 days, as shown in several trials in the region, or even shorter regime of 3.5 days, which was a study done by the IMR team at Alexishafen in collaboration with colleagues at UWA and Curtin. So there's really a nice set of tools and strategies here that can start to be explored. There's also single-dose tafenoquine, and for a long time, people in the malaria community thought that tafenoquine was really going to be a silver bullet for vivax elimination because this single-dose administration overcomes the adherence challenges that I've mentioned. However, it brings with it some other challenges in that a single dose, by very nature, cannot be reversed, and so it really requires strict regulatory requirements around accurate G6PD testing and pharmacovigilance to be established within quite a strong health system to be able to meet the requirements for tafenoquine to be used. Moreover, there's also recent evidence from the Inspector trial in Indonesia that the current dosage, as well as co-administration with ACTs, may not be optimal. And so there's more work that needs to be done in this space to optimise tafenoquine for a setting like PNG. And again, that's work that the IMR is partnering with global leaders on. And Leo and Mary are going to talk a lot more detail about how some of these new tools will apply in the PNG setting. So just to finish, I wanted to highlight, however, that a really big challenge, even when we get effective primaquine or tafenoquine treatment into facilities being used to treat those patients who are presenting, is that we still have people in the community with hypnozoites that are going untreated. And so a remaining challenge is targeting anti-hypnozoite therapy towards all of those hypnozoite carriers. And a program of work that Ivo Mueller and Ria Longley and Michael White have really been spearheading around p.vivax serological screening is showing considerable promise. This detects individuals who have been previously exposed to a blood stage vivax infection and uses this exposure as a marker for the presence of hypnozoites. And it's been shown in several studies now to really identify those people who are at risk of recurrent infections. And this could really fill the gap in the toolkit that's needed. And so as a result, can't get that to advance. There we go. The Bill and Melinda Gates Foundation have actually supported the establishment of a vivax serology partnership that will really work to try and accelerate the development of tests and strategies that could really push this approach forward in the kind of timelines that we need. We've talked a lot today about partnership, and the idea here it will harness the skills of academic groups, product developers, as well as national malaria control programs and policymakers to try and ensure that test development and evidence generation can be aligned with global and national policy processes. And one of the early pieces of work that the policy and implementation pillar of VISPA has done is work with WHO around preferred product characteristics for tests for risk of p.vivax relapse. And this is currently open for public consultation until the end of the month. So in summary, the 2030 malaria elimination targets really are of vivax-specific case management and prevention strategies are accelerated. Globally, effective radical cure is predicted by the health economists to prevent 6.1 million cases of acute illness annually and reduce the global cost of vivax malaria by more than 27%. So I think there's a consensus that the time for inaction in this space is over. We've had 60 years of inadequate use of primaquine to prevent relapsing vivax infections. And it's my hope that vivax endemic country-led programs such as you're going to hear from Leo and Mary, that will generate locally relevant evidence on how best to safely implement revised case management approaches, will guide local policy and practice and really drive forward the VIVAX agenda. Thanks so much.
Another vector-borne disease that is still a major problem in Papua New Guinea is malaria. Last year alone, the NHIS system that the country uses recorded more than 1 million cases of malaria. 30% of those were due to VIVAX malaria. And if we talk about the elimination, falciparum responds quickly to malaria control interventions, but VIVAX is one of those parasites that, as you all know, hides away in the liver and keep coming back, whether in the form of relapses or reinfections, and this makes VIVAX a difficult parasite to deal with. And so when we talk about elimination, we cannot just talk about common parasites like falciparum. We have to think about VIVAX as well. And so VIVAX is a really important species when you look at it in terms of elimination, and that we have to deal with. And this would mean having appropriate tools, and tools may include drugs to treat VIVAX effectively, as well as tools that can help us to identify people who are G6PD deficient and who might hemolyze if they are given drugs like primaquine, and how do we optimize those doses of primaquine to make it safe and effective and with good efficacy for use in our national malaria control programs. And so VIVAX would be another important topic when we talk about elimination.
Been able to have a very close and good working relationship with the Institute of Medical Research. They happen to be one of our key partners, especially in terms of the kind of operational research they conduct depending on the requirements of the program, and many other activities they conduct. We've been able to build this relationship over many years, and it's now a very stable working relationship that we have. It goes a long way in terms of assisting the National Malaria Control Program in achieving some of its goals and some of the activities that we plan in terms of malaria control. Having said that, as we all know, malaria is supposed to be eliminated in the year 2030, and part and parcel of the work that IMR does is assisting the program to decide on the kind of strategies we are able to put in place to achieve these elimination goals that have been set not only for PNG but for the rest of the region in this WHO Western Pacific region. Well, for the malaria program, we see our priorities as like at the moment we are looking at concentrating on few strategies which include bed net distribution, treatment and diagnosis. But I believe as we move forward, we'd like to be able to try out new tools in terms of, like we haven't thought much about vector control issues, control of breeding places, and also getting rid of breeding sites and all that. So that is another option we look at. And also one of these other priorities is that I think we need good stratification of the country so we can implement all our strategies where it is most suitable. So what we need to do is, if we had our country very well stratified, then we can be able to decide where we can combine several of these strategies, including IRS where it will make the most impact. So, and another big gap is the issue of vivax. I think the vivax issue is not new to any country in this region. I think vivax issues have been handled, throughout many countries in this region, including Solomon's, Vanuatu, and they still have issues with vivax, and where PNG has got the highest, probably the highest number of vivax cases compared to our two neighbors. We still do need to do a lot more work on vivax, and that includes whether we want to do short course therapy, like instead of 14 days, come down to 7 days with a higher dosage. And also we are thinking that should we continue with the 14 days, and of course the compliance is not so good with 14 days, so we as a program are beginning to think about whether we want to go into the use of G6PD testing on site before we treat people with vivax. It's a very, very difficult thing to do because of the techniques required in being able to maintain and do the G6PD testing. It depends very much on the kind of tests that we choose to use, but that is a very big gap, because at the moment we are trying to decide, okay, if we do move towards the path of doing G6PD testing before treatment, who is going to do it? Where will we set up this test? Is it the health center, or is it the aid post? So these are questions that we have yet to answer, and that, of course, IMR is already doing some work on, which will actually inform program as to the direction we want to move in, especially with vivax and new vector control tools. That is where their operational research becomes very, very handy for the program itself. We in the program, we don't have the capacity to do this, so we depend on IMR to be able to get this information and inform the program, so we can change strategies. There are a lot of research going on, different projects with IMR and the department work with, like Strive. They do quite a number of different things, and benefits the whole program. And I think the way all this has come together is something I'm quite pleased about, because instead of getting one organization to do everything, we do have all these collaborators doing different things, which are all for the benefit of the program. So I think that is where we see this research as being very important. And of course, the one other thing that the program is quite happy with the IMR at the moment is, I know they have got a lot of work to do, but I think the issue of primaquine is come up a lot in many of our discussions, and one aspect of primaquine usage is department plans to renew our treatment policy, but at the moment we do not have the information on vivax and issue of primaquine. So we have requested IMR to do some work on primaquine. We sort of await the outcome of the studies they are doing, so that it gives us it gives us the knowledge to be able to say, okay, this is probably the way we move forward with the use of primaquine. And interestingly enough, we do have programs out in the rural areas that are demanding the use of primaquine, and it's quite a tricky thing. That's why earlier on I did mention that if we shorten the course, or if we do the testing before treatment, and those may be able to solve the problems, but it's not as easy as it sounds. So those are issues which I think IMR has been able to be very useful in our in the program that we sort of manage at.
So, as mentioned by our previous presenters, malaria remains an important cause of both acute and chronic illness, and PNG contributes a high burden of cases in the Western Pacific region. One of the major challenges to malaria control efforts that we see is Plasmodium vivax, which is a species of malaria that's very prevalent in PNG. So, the main issue with this species is its biological ability to lie dormant in liver cells as hypnozoites and escape detection and treatment, and later become a source of relapsing infections, which can lead to illness and death and sustained transmission. So in PNG, we currently only have one medication that can be used to treat this dormant hypnozoites that hide in the liver, and that's primaquine. But the issue of using primaquine is the risk of hemolysis in individuals who have G6PD deficiency or glucose 6-phosphate dehydrogenase deficiency. So it's an enzyme in the body that protects the integrity of the red blood cells. And if you are deficient and you take primaquine, you may hemolyze. So the main challenges that we see for malaria control in PNG, as I mentioned, is the high burden of vivax, high proportion of cases in remote and rural areas, and we also see a poor adherence to the current 14-day regimen of primaquine. We also see that there's a need for higher dose of primaquine because of the strains of vivax malaria, such as the Chesson strain, and we also see that due to the risk of hemolysis in patients with G6PD deficiency, it's often difficult to or people are discouraged, health workers are discouraged to prescribe primaquine. So the rationale for this study is basically that our current malaria surveillance in the country does not allow for identification of repeat presentations, and identifying these repeat cases would allow us to quantify the burden of this recurrent p.vivax that is posing such a high problem in our communities. And we also don't currently do lack of routine G6PD testing. There's also lack of effective primaquine treatment, which, as I mentioned, is partly due to the reluctance to prescribe primaquine because of the risk of hemolysis in those who are deficient for G6PD. So this project is looking for the evidence to drive the implementation and scale up of G6PD testing and effective treatment regimens. So in PNG, currently under the PAVE project, we have 2 research projects that are ongoing, the strengthening vivax surveillance in PNG and the feasibility of high daily dose short course primaquine after G6PD testing for the radical cure of Plasmodium vivax malaria, which the short name is SCOPE. So these 2 studies will be occurring at the 4 study sites indicated on the map, which would be East New Britain, East Sepik, West Sepik, and Madang. So for the first study, the main aim is to strengthen the quality of routine data available to the malaria program by supporting the additional collection of routine data, and this would help us to quantify the burden of this recurrent vivax malaria that we're seeing. So the surveillance study is a health facility-based observational implementation study where the research staff work alongside facility staff to collect data with study questionnaires. And the main thing we've been introducing is a unique ID number that is recorded on the patient's clinic book and also in the register books at the health facility. So this number will help us to track the patients on the number of visits they make to the health center with a febrile illness and get them tested for malaria by RDT. So again, to help us capture all those repeat cases that are coming in. Additional data that we collect through our questionnaires, the number of Primaquine tablets prescribed, and as part of the study, also strengthening the education provided to the patients on the side effects of Primaquine and encouraging them to return if they observe any adverse events. So data collected as part of this study will form the baseline data for the SCOPE study. So for the SCOPE study, the main study aim is to determine the feasibility and cost effectiveness of introducing a revised case management package to facilitate a well-tolerated and effective radical cure of patients with vivax malaria. Currently in PNG, we don't, or our current policy and standard treatment of care is we don't routinely test people for G6PD prior to prescribing Primaquine. The Primaquine dose that's currently being given is 3.5 milligram per kilogram over 14 days with artemether-lumefantrine, and we don't do treatment supervision or formal pharmacovigilance. So with the SCOPE study, we'll be introducing a revised case management package, which will try to address some of the challenges that we mentioned earlier. The first thing we'll be introducing will be point of care quantitative G6PD testing using the SD biosensor prior to the use of Primaquine. So the second point would be introducing a higher total dose of 7 milligram per kilogram total, which would be, of course, prescribed after the G6PD activity has been determined through the SD biosensor testing. The third point would be to improve patient counseling tools and processes, including pre-treatment education and just educating the patients on the importance and risk of Primaquine therapy and supervision and supervising their first dose. The fourth point would be having community-based clinical reviews done at day 3 of treatment to encourage adherence and facilitate detection and management of adverse reactions to treatment, which would then help provide evidence for scale-up. And finally, improving malarial surveillance and pharmacovigilance to support wider scale use of these interventions. So the SCOPE study design is, again, health facility-based implementation research study, and it will be implemented in a phased approach. So we'll have about 3 stages, the first stage being the pre-implementation, the stage 1 being the safety study, and stage 2 implementation study. So for stage 1, it will be occurring at 2 sites in PNG, East New Britain and Madang, and will be run for about 6 months. The 2 main objectives of this study, of this stage of the study, the first to ensure that G6PD test can be implemented and used at points of care to reliably identify patients who may be at risk of Primaquine-induced hemolysis. And the second is to ensure that patients with early adverse reactions can be identified reliably at day 3 review. So for PNG, the sample size or the number of patients we'll be looking to enroll will be about 300, and these are for the inclusion criteria, people more than 1 year of age who have hemoglobin of more than 8, able to be reviewed at day 3 and day 7, and women who are non-pregnant or lactating. The treatment will, as mentioned, be according to G6PD activity. So those who fall within the normal range or have more than 70% of activity will receive PQ7, which is 1 milligram per kilogram per day for 7 days. Those who fall in the intermediate range for 30 to 70% activity will receive PQ14, 0.5 milligram per kilogram per day for 14 days. And those who are severely deficient or have less than 30% of activity will receive weekly Primaquine of 0.75 milligram per kilogram for 8 weeks. And on day 3 and day 7, we'll follow up the patients and just see if they have any adverse events and do a repeat HB measurement. In stage 2, which is the implementation study, this will be carried out at all 4 of the sites for about 12 months. The main objective of this stage of the study is to determine the feasibility and cost effectiveness of the interventions. So the study population for this stage, the healthcare providers who will be mostly in the qualitative component, and the patients who make up the bulk of the participants, with about 5,000 that we're hoping to enroll. So the treatment will be as mentioned in the previous slide, and review will be done on day 3 by the village reporters to help identify those with early signs of intolerability and otherwise promote adherence. So in summary, we hope that through this program of work, we'll provide evidence to facilitate widespread adoption of improved case management tools and processes for safe and effective radical cure of patients with p-vivax in PNG and throughout other vivax endemic countries. And if successful, these combined improvements may be adopted by PNG Department of Health and across all facilities across the country.
Thank you for bearing with us and still sticking with us to the over 120 viewers that we still have with us today. Thank you for the presentations that we've just seen around malaria and lymphatic filariasis and how we can use research and the work of research to help eliminate this as a disease burden in our country and in our region and globally. I'm going to throw out a really, really, really corny malaria joke, but bear with me. I didn't think I'd like being the host of a parasite, but it's really grown on me. So you're welcome. And on that note, we're going to move on in our program to the last. I'm going to present the last two, I'm going to introduce the last two presenters for today. The first presentation that will be played is a presentation on the road to eliminating cervical cancer. And this will be presented by Dr. Pamela Toliman and Dr. Paulius Ripa. Excuse me, Dr. Ripa. Dr. Toliman is a senior research fellow at the IMR, and Dr. Ripa is one of our really, really strong research partners and advocates for us at the Western Highlands Provincial Health Authority. He's the Director of Curative Services at WHP-PHA and the Program Coordinator in Western Highlands for the elimination of cervical cancer. So that's the first presentation that's coming up. And then the presentation following this one will be from Dr. Janet Gare, who is a Senior Research Fellow and the head of the Sexual and Reproductive Health Unit at the PNGIMR. She is also a principal investigator on the accelerating uptake of HIV drug-resistant surveillance in Papua New Guinea, or what we know as the ACT UP PNG project. So without much more introduction, please enjoy the next couple of presentations from Dr. Toliman, Dr. Ripa, and Dr. Gare. Thank you.
Papua New Guinea has the highest incidence of and mortality from cervical cancer in the Asia-Pacific region. Compared with Australia, this age-standardized incidence of cervical cancer in PNG is 5 times higher, and the mortality rate is 12 times higher. Over the last decade, the PNG Institute of Medical Research and the Kirby Institute have led a substantial body of research aimed at addressing the huge problem of cervical cancer in Papua New Guinea. This research collaboration program designed and evaluated the first point-of-care HPV test and treat program for cervical cancer screening. Working with the PNG OBGYN Society, the PNG Cancer Foundation, national and provincial health authorities, community stakeholders and partners, our shared goal has been to identify the most effective, acceptable, efficient, cost-effective and scalable screening model for Papua New Guinea. We conducted the first field trials in any setting of an integrated point-of-care HPV DNA screen and treat model and demonstrated that point-of-care HPV testing of self-collected specimens has high sensitivity, specificity, PPV and NPV for the detection and treatment of cervical precancer, and that this is a highly cost-effective and acceptable model suitable for routine delivery at scale in primary health facilities in Papua New Guinea. And we also found that the point-of-care HPV screen and treat strategy was highly cost-effective compared to pap smear or visual inspection methods. The strategy would also have significant population level impact if delivered at scale in PNG. To screening 70% of age-eligible women twice in their lifetime would reduce cervical cancer incidence and mortality in PNG by more than 50%, even in the absence of HPV vaccination. A key aspect of this model of care is that it optimizes how clinical staff use their time. A 3-person team is able to register, test and treat an average of 32 women in a day. A positivity rate of 14% meant that 4 women required clinical assessment and pelvic examination, and over 90% of women who tested positive for high-risk HPV were provided same-day thermal ablation, while the rest were referred for more specialized care. In the case of visual inspection with acetic acid, the same team could only screen 16 women per day, all of whom require a pelvic exam, with many having indeterminate findings and therefore treatment not able to be offered in the same day. Key to our success in advancing this translation into policy and practice has been the paradigm shift in global policy from cervical cancer control to cervical cancer elimination. This shift has itself been driven by robust evidence from clinical intervention research, epidemiological and economic modelling, demonstrating the effectiveness and impact of the tools and innovations now available to us. In November 2020, the World Health Organization launched the Global Strategy on the Elimination of Cervical Cancer as a Public Health Problem. The strategy puts forward 3 coverage targets to be achieved by 2030 to place countries firmly on a path towards elimination of cervical cancer as a public health problem. The 90-70-90 targets are to vaccinate 90% of girls with the HPV vaccine by the age of 15 years, to screen 70% of women with a high-performance test by the age of 35 and again by the age of 45 years, and finally to offer appropriate treatment and management to 90% of women found to have cervical disease. In the second half of 2021, the PNG National Technical Working Group on Cervical Cancer developed new recommendations based on evidence from the PNG IMR-led field trials and the new WHO guidelines. HPV Screen and Treat was endorsed by the TWG and the Department of Health as the primary cervical cancer screening strategy in PNG in December 2021. As discussions around HPV Screen and Treat progressed in PNG, the PNG IMR Collaborative Group has played a lead role in securing a landmark regional program on cervical cancer elimination. The Eliminate Cervical Cancer in the Western Pacific program is a proof of concept project that will provide HPV vaccination and HPV self-collect test and treat services to over 100,000 girls and women in Papua New Guinea and Vanuatu between 2021 and 2025. In PNG, this program is coordinated by the NHNMRC Centre of Research Excellence in Cervical Cancer Control, in close collaboration with the Western Highlands PHA, PNG IMR and other in-country partners and stakeholders. The program is supported by Minderoo Foundation, industry partner CEFID, the national and provincial governments and development partners in Australia and the Pacific. In PNG, the primary initial focus of the elimination program will be in Western Highlands Province, where the program is being led by Jane Holden, Dr. Paulus Ripper and colleagues. Western Highlands is the first health authority in the Pacific to embrace the elimination agenda. A hub and spoke model is proposed in Western Highlands to ensure girls and women in rural and remote communities are not left behind as we advance towards elimination. The provincial hub will consist of the Well Women Centre, where point-of-care testing and same-day thermal ablation, gynecological referral are accessed. A provincial hub will also be the centre of clinical excellence in cancer care for management of early and late-stage invasive disease, palliative care and support. The hub will also be the provincial coordinating centre where all aspects of the provincial program are managed. The rural spoke is a rural health facility where point-of-care HPV testing and same-day thermal ablation or referral is accessed. Dr. Paulus Ripper will now give us an update on the activities to date in Western Highlands Province.
I am Dr. Paulus Ripper. I'm the Director of Curative Services in the Western Highlands PHA, and I'm also the Program Manager for the Elimination of Cervical Cancer Project within the province. The Elimination of Cervical Cancer Project is in line with the WHO recommendations, which essentially recommends a three-tier approach to the whole elimination of cervical cancer program. The first tier is the prevention bit with immunization of girls aged 9 to 14 years of age. The second tier is the screening for HPV infection, which we are already doing and it's well established. The third tier is effective treatment for those with invasive cancer. In terms of this three-tiered program, we've started with the cervical, the HPV screening program with the help of IMR and Kirby Institute, and that is now quite well established and is being done in two parts. One is the main central clinic within Mount Hagen Hospital, and the other one is a specially fitted truck that goes out to each district on a monthly basis so that we can screen women in rural areas who are unable to come into town. The immunization program is currently being planned to commence in February 2024. We have put in a submission to the National Department of Health to endorse this as a pilot project because the national government has deferred the HPV vaccination until 2025 or 2026. And what we hope is that this will be a pilot project that can be done in a geographical, a limited geographical location, and we can then be able to work out any of the issues that might affect nationwide rollout and be able to then deal with those. The third tier is the treatment, the diagnosis and treatment bit. We're now seeing a small number of women with invasive cancer during the screening process, and when they are diagnosed, they then have to be to have a pathological diagnosis and have appropriate treatment. In the first place, we don't have pathology services in Mount Hagen. In the second place, this takes a turnaround time of 3 to 4 months, and that delay is not conducive to effective treatment of the women concerned. The third problem is that we can only do a certain type of surgery. There are other more specialized techniques that we need to get our gynecologists to train, and all this is being planned, and we are in stages trying to put in place an effective service. I would like to take this time to thank the PNGIMR and the Kirby Institute for helping us to come to this stage of the journey where we've started off with a small screening program, and it has now come into probably the biggest well-established screening clinic in the country. We've had numerous occasions to sit down and share the experiences and be able to expand the program to the two other tiers for immunization and treatment. And we're also looking at continuing this journey because there are many different parts of this program will require ongoing monitoring and evaluation, and it is important that it is done in an objective and structured way so that it informs us to tailor the ongoing project. Unless we deal with all three tiers of this elimination program, we are unable to effectively deal with cervical cancer, which causes so much death and misery within our society. For me, I'm a pediatrician, but I've been heavily involved in this because for me, I've also had a personal investment in this because I've lost something around 6 to 7 relatives within the extended family who have died from cervical cancer, and I know the effects that it has on the extended family.
Good day, everyone, and good morning, evening, and night to those colleagues watching online. Today, I will be presenting on the challenges and the opportunities in eliminating HIV infection in babies who are born to positive mothers in Papua New Guinea from the ACTAB experience. So every year, globally, an estimated 1.4 million women living with HIV become pregnant. Untreated, they have a 15 to 45% chance of transmitting the virus to their children during pregnancy, labor, delivery, or breastfeeding. However, that risk drops to just over 1% if they take ARV medicine, both the mothers and children throughout the stages of infection. Globally, there were 1.2 million pregnant women with HIV in 2022, of which an estimated 82% received life-saving antiretroviral drugs to prevent mother-to-child transmission. In the same year, there were 1.5 million children living with HIV, a reduction from 2.5 million in 2020. Each day, and approximately 270 children are born with HIV, and the same die of AIDS-related diseases. There are some success stories of countries who have eliminated mother-to-child transmission of HIV and syphilis. The first country was Cuba in 2015, followed by Thailand, Armenia, Belarus, and Republic of Moldova in 2016. So we ask, how did these countries successfully reduce the number of HIV infection in their pediatric population? So firstly, what is similar across the countries? These countries, there's a universal health coverage backed by government-led and funders prioritized PMTCT programs. And there's early access to prenatal care, HIV and syphilis testing for pregnant women and their partners, and treatment for women who test positive as well as their babies. And there's also provision of reproductive engagement of communities and outreach to marginalized population in a manner consistent with basic human rights and gender equality. And finally, there's this integration of maternal and child health with sexual reproductive health and HIV services. So the integration underpins the WHO's new health sector strategies on HIV, sexually transmitted infections, and viral hepatitis, as it is fundamental to the attainment of universal health coverage and the realization of the Sustainable Development Goals. So where are we at in Papua New Guinea? We can have a bit of background on HIV. PNG has the highest prevalence of HIV in the Pacific. Recent estimate shows 1% of adults were living with HIV in 2002 alone. And there is also a strikingly high percentage of babies were born to mothers who are positive, about 34%. And children 0 to 14 years, they accounted for 19% of total 5,809 new infections in 2002 and made up 8% of the overall estimated people living with HIV in the country, as compared to 5% in 2019. So not all mothers who are not all mothers who are pregnant are accessing viral load before delivery. And we know also that there is also high loss to follow up with mothers in antenatal care. There were issues around pregnant mothers that was presented at the recent 2023 HIV and Pediatric Conference in Brisbane by Dr. Gamini Valley of the POM Hospital. She presented that there was low ANC coverage. Around 50% of mothers at least have one antenatal clinic visit, and there's high rates of unsupervised deliveries. Only 35% were supervised deliveries between 2015 and 2019. And there was not many women coming for second HIV testing in pregnant mothers or breastfeeding mothers of high risk. And not all mothers are having viral load before delivery. And according to the PNG guidelines for mothers who are pregnant, HIV positive mothers must be virally suppressed, meaning that they should have 1,000 copies of virus per meal at 4 weeks prior to delivery. And one of the issues that is common in the country as well is that when there is no partner involvement, then women tend to lose to follow up in care. So in her presentation, there was less than 1% partner involvement in the ANC care. So my next presentation is on ACTAP. So what is ACTAP PNG? ACTAP PNG is short for Accelerating the Uptake of Innovations for Detection and Monitoring of HIV Drug Resistance in Papua New Guinea. ACTAP was the program started in 2021 and has been ongoing at 2 sites, Haduru Clinic in Port Moresby and Tininga in Mount Hagen. So what is ACTAP offering? We are using GeneXpert platform to deliver HIV viral load testing for adults who are 15 years and above, and that includes pregnant women as well. We are doing HIV-1 qualitative testing for HIV-exposed infants who are 6 weeks through to 18 months. And we've also, and this is the first time that the country, we have introduced the MPMA analyzer, which is a assay that measures viral load testing for children who are less than 10 years. Currently, prior to MPMA, there were no viral load done for children because the amount of blood that's required for them for testing using GeneXpert is quite huge. So we also are offering laboratory-based HIV-DR PCR, drug resistance PCR, to those patients who have persistent high viral load after 3 months of enhanced adherence counseling, and also to newly HIV diagnosed, and that includes our babies and children as well. So from here onwards, I would like to present on key results, progressive results on ACTAP, on viral load testing and early infant diagnosis. So we have the total number of tests for viral load is 5,246. We have also tested, and of the 5,246, 4,428 are unique patients. Of those, we have about 499, which represent 11% of the tests were for children that were less than 15 years. All right, the next slide shows the suppression rate in children across the 3 sites, across the 2 sites in 3 years that the services that we provide for viral load. So here, according to the target that was set by UN to achieve by 2020, 95% of people who are HIV positive should be diagnosed, and of those who are 95% must be on treatment, and of those who are on treatment, 95% of them must have viral suppression. And as you can see on the slide, we have in both sides, our children's viral suppression remains below the UN target of 95. All right, the next slide is on the viral load suppression in women attending antenatal care. So similarly, viral load suppression observed here is the same as the children. We haven't reached the 95 global target of people who are on ART should have viral suppression. So the table on this slide shows the number of tests that were conducted on the GeneXpert platform for infant diagnosis. So a total number of EID tests that were conducted were 1,235. The total number of unique patients tested for infant diagnosis 1,151. So in both sides, the positivity rate for babies who were born positive was 8.8%. Of those unique patients tested, 56 returned for the next infant diagnosis test. Of them, one who was positive initially became who was negative, but then negative initially became positive. On this slide is a figure showing the first infant diagnostic test results of HIV-exposed babies according to the infant age at the time of testing. In both sides, we were able to detect 33% of HIV-positive babies when they came in around 6 to 8 weeks for testing, and then after 8 weeks we were still able to test and detect HIV positive babies turning HIV positive up until 18 months of age. So this slide shows the turnaround time. So when we were using point of care, testing, it means that the turnaround time has to be shorter. So in those two sides, we were able to provide 53% of the infant diagnosis tests were provided to the clinician on the same day. And in that same day, we have a breakdown of hours that more around 46% where doctors received the result within up to 3 hours, and around 12% between 3 to 6 hours, and around 41% were more than 6 hours. So in the current ECTA program, we are also doing behavioral qualitative interviews, and we're also doing acceptability of point of care testing for both viral load and for infant diagnosis. But what I've put up here is for only infant diagnosis. So this is a picture of Dr. Angela Kelly and one of our senior social scientists, Ruthie Boley, at the recent standing next to a poster presentation at the recent HIV and pediatric conference in Brisbane. So according to our acceptability testing, there's been so many good comments about the test that we are doing, and I have only two quotes that I will quickly read. From my nurse at the Well Baby Clinic in Moresby. Says, with the infant diagnosis now, it is good. We notify them early, and for those who are positive, we disclose to them the same day, and we collect the blood and we start them on medicine as fast as possible. Okay, another a teenage client at the Well Baby Clinic also comment that previously I used to wait for 3 weeks. Today I just did my blood test and they told me the result. I'm so proud. My result is fine. I'm happy. I have to take my medication on time. I have to make it easy for myself. So that's another comment from a clinician at the antenatal clinic. For me, the exciting thing that is going to come out of this is the prevention of parent-to-child transmission. We would like to see zero transmission to children and being available to test if a timely way in a timely way and have the result available to start women on treatment and have results to guide us in the labor and delivery. So these are comments, and there are more comments that are in favor of the point of care that currently ECTAP is providing at its sites. Sadly, in ECTAP, we see that there is 1 in 3 children who are born with HIV drug resistance. So the slides above shows that we have done 168 DBS for HIV drug resistance. Of these, 30 of them were from children, and of those who went to drug resistant, of the 30 who went for drug resistant testing, 10 of them had viral load, not viral, pardon me, they had HIV drug resistance, and they were resistant to NRTI, the NRTIs and NNRTIs, which the country has done away with after the national survey, drug resistance survey conducted and led by IMR showed 18% prevalence of NNRTIs. However, we know that infants are still given nevirapine as a prophylaxis, and based on these results, there are discussion on seeing how the prophylaxis treatment combination for the country can be changed to accommodate for this prophylaxis treatment of nevirapine. So we had a special pediatric case, a 2-year-old patient from Hillary Clinic whose HIV-DR test came back, the result came back, and it shows that the patient was resistant to all the NNRTIs and RTIs that currently available in the country. Fortunately, in consultation with a HIV pediatric specialist, UNSW, Dr. Eden Bartlett, and our in-country pediatricians, we were able to propose and change the treatment of this special child. So coming towards the end of my presentation, what has ECTAP shown? So ECTAP has shown that it is key to include a HIV-DR testing in the HIV program. So it has demonstrated the value of active drug resistance, and scale-up of these capabilities combined with viral load testing will enable better treatment and care for PL-HIVs. HIV-DR also will be included in the new HIV strategy, and in the space of PPTC, in the space of pediatric HIV, it has also highlighted a need for greater attention, failing to eliminate vertical transmission. And there's also poor HIV viral load coverage in ANC due to influence of prophylaxis decision, and ECTAP has also shown that there's gaps in pediatric HIV viral load suppression is extremely poor. ECTAP has also shown that doing HIV drug resistance at baseline is very important and can be part of an ongoing HIV drug resistance surveillance in the country. So currently we are transferring HIV-DR technology from Sydney Perth to PNGIMR lab in Goroka. ECTAP has also shown that point of care infant diagnosed testing is acceptable, and also it provides a faster turnaround time of results back to the clinician for timely decision making on the children's treatment. Also, ECTAP has shown that there's more than 60% of infants that are tested at 6 weeks, which means that we are now seeking approval or to introduce bed testing as recommended by WHO. And based on the outcome of ECTAP, the Department of Health would like ECTAP to be expanded into 2 other provinces in the country. So where is PNG's progress towards elimination of HIV, syphilis, and hepatitis B? So briefly, I'll just mention of what has been done, and it will, of course, it will take PNG a while to bring to reach the zero infection. So currently, there's a draft of the strategic framework 2023 to 2027 being put together by Dr. Kama and the team at the National Department of Health. Gene Expert platform in the last technical working group, viral load sub-technical working group, Gene Expert platform has been endorsed to be used throughout the country for infant diagnosis of HIV, and there's a plan to expand on infant diagnosis and viral load testing to other provinces, as I mentioned before. And the country is also rolling out the new triple HIV test strategy. In conclusion, to close the gaps to eliminate vertical transmission in our setting of high HIV prevalence, we need to identify and support mothers at risk and help pregnant women and breastfeeding mothers achieve and maintain viral separation by providing improved access to care and enhance social and adherence support. We also need to intensify community-based HIV screening to reach pregnant women and young women who are not attending ANC. And a classic example which has been very successful was the IBBS survey, where it was the first time the country had introduced where we used point of care tests to test for 5 different pathogen, and viral load was one of them, doing viral load, providing HIV testing as well, and that involving communities, and community were able to mobilize to the site and been tested for. So to reduce vertical transmission in women who are not aware of their status by delivery, we need regular testing during pregnancy, at delivery, and postpartum is required with provision of PrEP to those who test negative. I think this brings me to my at the end of the presentation, and I would like to take this time to acknowledge the Center for Health Security for funding ECTAP. I would like to acknowledge Global Fund for providing the cartridges that we're using for infant diagnosis and viral load testing, and all the key partners who are involved in ECTAP program, and not to forget about all the hardworking staff, ECTAP staff in both sites, Mount Hagen, Heduru Clinic, and in Mosby, and Tininga Clinic in Mount Hagen. So thank you all for listening.
And we've come to the end of all our presentations for another year of virtual symposium. Thanks to the over 120 viewers that are still with us. We really appreciate you sticking it out with us today and hearing about all the amazing research that the PNGIMR is involved in, is partnering in, and is leading. The reason I have these two lovely gentlemen next to me at the moment is that we will have a Q&A session. We haven't had that many questions today, so either we're doing a really good job, or maybe there's other questions that are forming that you'll get back to us at some point. But the couple of questions that we do have, I have the director and the deputy director here to respond to. Before we get into that Q&A session, I just want to, as the MC today, say thank you very much for your attention, your support, to all the presenters. Fantastic job. It's a lot of effort to put those together, given all of the work priorities and commitments that you have. So thank you for everyone that's contributed today. I mentioned them at the beginning, the IT support. Shout out, guys. Thank you so much for supporting us today to get this this program all completed. Last shout outs today also to the School of Medicine and Health Sciences from the UPNG, James Cook University, my alma mater. From viewers in Cambodia, we have viewers in Perth, and last but certainly by no means least, Mama na Papa Blo IMR, I will put it that way. Michael and Deborah Lehman, thank you so much for your support and for watching with us today. And so on that note, we're going to jump into a Q&A session, which I will kick off by asking Professor Pomat and Dr. Laman the questions that we have been provided. If you have any other questions, please, the chat line is still open, so send those through. But our first couple of questions today is around both the malaria vaccine and the HPV vaccine. In terms of malaria vaccine, and I'm not sure who sent in this question, but thank you for that question. What is the plan for malaria vaccine, or to introduce the malaria vaccine in PNG? And also the same for HPV. What's the plan for rollout of vaccines in the HPV program? So I'll throw to you both to tell.
Yeah. Thank you. I'll probably start, and then Moses, as the scientific head of the institute, will answer a lot of it. So thank you. Those are two important questions. And vaccine is indeed something that we want to introduce to ensure that we prevent disease. and it's the #1 public health solution for diseases. So on that note, I will now ask Moses to inform us about the plans for malaria vaccine and also the HPV vaccine. Thank you, Moses.
Yeah, thank you, Willie. Those are really important questions, and we know vaccines are really important. Is really important intervention. Well, first of all, for the malaria vaccine, as we know, 30% of the burden of malaria in Papua New Guinea is still due to vivax malaria, and this vaccine has been shown to have very good safety and efficacy in falciparum, and definitely useful in African settings where falciparum predominates. It also predominates in our setting, but for any intervention, whether it's the HPV vaccine or the malaria, it's not about efficacy and safety only, but it's also about effectiveness and cost effectiveness of it as well. And we know Papua New Guinea struggles with interventions that do not reach the efficacious results that we see in clinical trials, mostly because of challenges in the healthcare system, but also cost implications and low vaccine coverage in the entire country. For example, the whole country has a vaccine coverage rate in its health systems challenge of, on average, I would say less than 50% in most provinces, and our partners, the provincial health authorities, are fully aware of this. So it's not so much anymore about whether our research gets translated or not. We work, probably what happens 20 years ago is an old story. What we do nowadays, we work very closely with the National Health Department and the provincial health authorities and the engine rooms, whether this be the Pediatric Society or the ONG Society or National Malaria Control Program or HIV-TB program. So those relationships are never like before. Those are very strong. And if we say that, how do we translate? It's already being translated in many forms. You take the LF triple drug therapy, for example. It's not only become a program that is rolled out by PHS like in Eastern Britain that led to treating 300,000 people, coverage of more than 90% with a triple drug therapy. This is not an IMR, this is an implementation led by the Provincial Health Authority. Similarly, if you look at the HPV vaccine, based on original studies that the teams at the IMR have done, leading to now this being absorbed into the Department of Health, and the government is now trying to fund point-of-care testing in provincial health authorities around the country. These are already being implemented. So it's an old story to think that IMR does not work with the provincial health authorities, National Department of Health, or regional bodies. You look, apart from examples of global guidelines change in LF, you look at BedNet bioefficacy issues. The original studies that identified BedNet bioefficacy were led by our entomology teams at the IMR. And that led to not only changes in BedNet brands in country and continue monitoring and evaluation, but also all the way up to WHO, Global Fund, is aware of this, and the regional bodies. We participated in APOLMA board meetings 2 months ago to inform them about those challenges. The WHO, the highest level is informed, regional bodies are informed. So I guess the idea that the IMR is well known internationally, but not locally, is an old story. It's an old story, and those have really changed in recent years. So I guess it's covering both the vaccine question and the translation in one answer. Thank you.
Thank you, Moses.
Thank you so much. Which is the question I didn't read out, but thank you so much for attending to it, Moses. So the other question that we had was around how PNGIMR translates what we do in research practice into policy, and yeah.
Maybe I'll just add that aside from what Moses has said, a lot of the IMR scientists are on technical teams that the department has, which then feeds the evidence that we have directly into the department's programs. So there's a few of our scientists that are on different boards that ensure that the evidence is directed towards implementation, but also the challenges from those implementation are fed back for any further research evidence that can be gathered to ensure that the system works well. So thank you. Hopefully that answers your question.
Yeah, if there's no other questions or comments, I think we can, what I would like to do is to throw back to Professor Pomat to say some final words in closing the symposium today. Thank you, Prof Pomat.
Thank you. There's 3 of us here. If you have any questions, please fire away. And if your fingers are not fast enough, then we might have to close. We have 3 minutes. No gut? So on that note, I want to acknowledge everybody who attended this symposium. I'm glad that we have a lot of very committed people who want to listen to and be part of the research activities that we are working on or working with. And especially I want to thank our media team who did really well. Young Barry, he went around Papua New Guinea to do all the different videos. And so we're really glad that we have such a talent within our within the staffing here. So also, I think Ellie also went up to Jiwaka to help with the malaria control or the implementation of the malaria control program of the research, and see the videos that we saw came from that work as well. So I want to thank our media team, our IT team for ensuring that we continue to communicate with all of you. And I guess that's part of the successes that we've had around communication and partnership and communicating with all of you as our partners. So on that note, I want to thank everybody, including Nalisa here, who's been a really great host, and all the team that are in the background answering your questions. I hope if you have more questions, please send them on. Maybe you can direct them directly to myself and Moses as well, if you think about them later on. Thank you to Webcast. You've done a really marvelous job. And thank you to Anne also for ensuring that everything was put together. And I think our biggest thank you to whoever talked to PNG Power to make sure there wasn't any blackout. So thank you very much, everybody. Hopefully there were no blackouts in all the IMR sites, so you were able to see everything that that was provided this morning and this afternoon. Thank you, Joseph at Webcast. Thank you very much. I think that's all.